today? How's the sound? Excellent, excellent, guys. Thank you very much. So let's start, okay? Today we'll talk about emergency drugs. That's very important to be used when you have a very sick and critically ill patient. So we will talk about, vasoactive drugs. We'll talk about inotropic medication that are used in emergency. Yesterday we covered the RSI medication. Today we'll be talking about vasoactive and inotropic medication. Okay, guys, I will start again. Thank you very much for your positive comments and for being always in line with us. It's a pleasure to be with you. So I'm not sure if all of you have come across using a vasoactive and inotropic medication in emergency. All of you using the inotropic medication and vasopressors in emergency. You use the infusions or you shift patient to ICU and they can. So tell me, guys, do you use the vasoactive drugs in emergency, inotropic medication in emergency, or you start them in ICU? You shift your patient to ICU. Okay, excellent. So you are using the vasopressors and you are using the inotropes in emergency. So let's start. So there is a little bit confusion about these medications and the mechanism of action for this medication, how to use them, when to use them, which one is better, which one is more safer to be used if your patient is very sick, hypertensive. So we'll discuss all these, indication, how to use them, how to make sure that the patient is stable while he's in inotropic medication or vasopressor. So let's break down the ice at the beginning and start to see some definition for these medications. So when we talk about inotropic medication, we're talking about medication or substances that alter the force of muscular contraction, whether in a positive or a negative. So inotropic might be a negative inotropic effect for the medication, might be a positive inotropic effect for the medication. And the main, concern here is the muscle or the contractility of the heart muscle. So some medication might be, positive inotropic, which is increased contractility. Some might have a negative, impact in the contraction of the muscle and called negative inotropic effect. Vasopressor, it's a medication or agent that does or cause or produce vasoconstriction, and it raises the blood pressure without an effect on the muscular contraction or in the muscle. So it is like increasing the systemic arterial pressure unless otherwise specified. Vasodilator, those medications that dilate the blood vessels, and chronotropic effect. So that is for the medication that causes change or alter the heart rate, whether in a negative or in a positive aspect. So you could have medication that have a negative chronotropic effect, or you could have a medication that is a positive chronotropic effect. Another medication which is, very similar when it comes to the vasodilators is called hemodilators, but those agents have, a nice mechanism that are using a dilation effect or vasodilator effect. At the same time, it does some inotropic, effect. So they have positive inotropic effect, and they do also vasodilator effect. Lysotrop, these are medications that cause relaxation or the function of muscle and chambers of the heart. Other definition also might be for this medication is dromotropic, which is does alteration or changes in the impulses of conduction of the heart, whether it's positive or it's negative. I know my colleague will speak in details about the sepsis and shock, but just to give you an overview, when a patient arrives, to emergency and he's sick, he's critically ill, he's in a shock state, those patients, they have imbalance between their oxygen supply and demand, resulting in development of tissue hypoxemia, or there's no perfusion, or there's tissue hypoxemia, there's no oxygen reaching to the tissues or the cells because of poor perfusion, whether because of sepsis or because of hypovolemic shock or because of cardiogenic shock. But the end result is that the tissue is not well perfused. The end tissue, there's no oxygen reaching to the tissues and cell, and this is push the cells and the tissues to choose another mechanism to induce energy, because all of you that all cells need energy and need ATPs. They need glucose, they need oxygen to able to do the cycle and produce the energy. Now, when the oxygen is not reaching to the cells will try to choose another mechanism, a backup mechanism where they can do anaerobic, metabolism, and this, end having, accumulation of lactic acid. However, it does make some energy, but the energy that is coming out from anaerobic, is about 2 ATPs only. So it's not enough to make the body survive, and the patient became very lethargic and very drowsy, very hypotensive, and became very sick. So how we can help patients when they arrive with such a situation? We need to make sure that perfusion is well maintained in the vascular and the vessels. Make sure that the oxygen is reaching to the tissue and to the cells. So how we can do this medication? We need to maintain reasonable hemodynamics. And when we talk about hemodynamics, we're talking about the study of the fluid in the inside the body. So we make sure that the flow of the fluid is going to the tissues, is going to the cells. So we start with the fluid resuscitation. How much is good to resuscitate patient? That's depends case by case. If it's a hypovolemic shock, if it's septic shock, if your patient cardiogenic shock, if your patient has a poor cardiac muscles, he cannot tolerate to be overloaded with fluid. So this is a clinical judgment that the physician has to take care of this. Some patients they need a volume. So when you give them a volume, you restore their circulation, and you make sure that the fluid and the blood and the oxygen reach into the tissue. And this is again can be an easy fix. With the fluid restoration, that's an easy fix. You just maintain fluid running for the patient, push a fluid, push volume expander, push blood. This, will solve the issue. But if the issue is not, about, talking about fluid, we're talking about, the need of vasoactive agents. So when we talk about vasopressors, we're talking about medication that they raise, blood pressure. Inotropes, they raise blood pressure. Now, remember all of you that most vasoactive agents have mixed effects. So they cause, change in blood pressure, in the blood flow and perfusion. So they get mixed together and they have mixed effects. So if you're talking about one medication, it might affect the blood pressure, it might affect the systemic vascular resistance, it will affect the perfusion. But there are some, variation in the degree how much they affect, how much they are good. And this is when it comes to the, to the role of the emergency specialist, okay, to decide which medication is better. So the injury of the patient, the shock happened already. When we want to restore, the perfusion to the patient, we should be alert, we should be mindful to choose the right medication, because if we choose the wrong medication, we will make the scenario worse. Let me make it clear in Arabic for those who need, some Arabic translation. So some patients, بعض المرضى already shock حدثت, that's it. So we have to be aware. ومقتنعين وعارفين إنه الشوك حصلت للمريض. الآن how to treat it. كيف نعالج هذا الأمر؟ لازم يكون السبيشاليست عارف جيدا إنه أي دواء من هاي الأدوية اللي راح نستخدمها راح يفيد المريض. لأنه في بعض الأحيان إذا استخدم دواء خاطئ أو دواء لا ينفع في نوع هذا type of shock، ممكن يعمل ايش؟ complication اكثر ما يحسن وضع المريض. This is the point. The specialist has to be mindful which medication is more suitable in this condition. The other thing, when we're talking about the cardiac output for the patients, okay, now if a patient in a shock, you don't aim for him to restore his normal cardiac output. You need the minimal cardiac output that provide, the minimal perfusion to the tissue. So you're not looking for somebody who's healthy and you want him to have a normal cardiac output. You want, the minimum that could restore the perfusion. So you're not aiming to bring the patient, if he was 0, bring him, to if his normal, example number, if his normal, cardiac output 50 example, or just for example, and you want to bring him to 50, no. So you aim like 25 and slowly you start, looking to achieve goals, but you don't aim quickly with this medication and you raise everything in the inotropic support or vasopressor. This can lead to, ventricular arrhythmias and could be a lethal arrhythmias for those patients. So you're going to be logical when you treat your patient. You're going to be mindful, okay, about the complication of this medication. Now, these vasoactive agents have individual effects. They have mixed effects. As we're talking about, individual. So some of them, they have only solo effect. They don't affect other, other part of that, like, if we're talking about blood pressure or systemic vascular resistance or talking about peripheral vascular resistance, does not have that effect. It will be effective only in the cardiac muscle, in the inotropic effect. Some of them, they have mixed effects. So they affect 3 or 4 parts. and some of them they are overlapping. هنالك تداخل في بنتائج الدواء، فبالتالي الشخص الذي يستخدمه لازم يكون he has to be smart، أن يكون ذكي عشان يعرف يستخدم أي دواء في حالة الشوك. And some of them are dose dependent effects. So if you play with the dose, the higher you go, the more you stimulate, receptors. The lower you may stimulate single receptors. So you need to be judgmental and logical when you use them. And some patients, they might need one or two, medication at the same time to make sure that you hit all the receptors or, stimulate all the receptors at one time. What are these receptors that we're talking about in المحفزات الموجودة في الجسم؟ alpha receptors, beta receptors, beta 2 receptors, and dopaminergic receptors. These are the receptors that might get, activated if you started these vasoactive medication. What we mean when we're talking about, alpha receptors. Alpha receptors is purely, vasoconstrictive of the artery. It does not do anything else. So if you have a medication that stimulate or activate alpha receptors, I should be aware that this one will cause vasoconstriction of artery. It will not does anything to the contractility. So if my patient really, you need to improve the contractility, this medication that have alpha receptors will not help me. So it does vasoconstriction, inclusive the coronary arteries. And you should be aware also that, this medication, it does also vasoconstriction to the coronary arteries. So the higher dose, you're giving this medication, the more you could cause damage to the patient. Vasoconstriction of veins, other areas that could, cause, constriction. Example, we were talking about ureter, vas deferens, hair, skin, uterus, when patient pregnant, urethral sphincter, bronchiole, gastrointestinal tract. So you should be smart enough that if you start this medication for a patient and you start in a high dose of vasoconstrictive medication or vasopressor medication, that means you stop the circulation or perfusion to certain organs or to certain, parts of the patient's body. And example, if your patient is intubated and you want to start him in a feeding and he's in a high dose of vasopressor, I know for sure that this medication already now constrict, the circulation to the gut. That means whatever I'm giving from nutrition or feeding, it will not get absorbed because there's no blood supply. The cells are not perfused in the gut. So you need to be, if you are on a high dose of vasoconstrictive, I know that the skin is not perfused well. That means if I'm giving subcutaneously medication, example, I know this medication will not get absorbed because the skin is not perfused. If patient have pressure injuries, pressure ulcer, this will be more complicated with the high dose of vasoconstriction or vasopressor. Also, it does have glycolysis and glucogenesis from adipose tissue and liver. It does secrete, from the sweaty glands, sodium reabsorption from the kidney. So these are mainly the function of the alpha receptors. Beta receptors, this was also medication that increase cardiac output. So we're talking about cardiac output. How does it increase the cardiac output? It does have a positive chronotropic. What we mean positive chronotropic? That means this medication will increase the heart rate for the patient. It does have a positive, dromotropic. It will increase, the atomicity of the heart. It does have a positive inotropic, will increase the increase the contractility. And as a total, this will increase the volume expelled with each beat, increase the ejection fraction of the patient, ending up increasing what? The cardiac output. It does also, the beta 1, increase the renin secretion from the kidneys. Beta receptors, beta 2 receptors, medication that dilate arteries to skeletal muscles. So you will have some certain dilatation now to the skeletal muscle and arteries, and these are causing also glycogenolysis and glucogenesis, smooth muscle relaxation, and in bronchi and GI, and decrease the motility in the GI. Now, the other type of receptors are dopamine receptors. And this is what we called about, dose dependence. So the higher you go with the dose, the more you stimulate receptors. Or if you go for 5 mics per kg per minute, less than 5 mics, so this is a dopamine receptors. And it does vasodilatation to the renal bed. It does vasodilatation to the mesenteric bed. Now, if you go higher from 5 to 10 mics per kg, now you stimulate beta 1 adrenergic effect, and this will increase the cardiac output, will increase the heart rate, will increase, chronotropic and tropotropic effect. If you go higher, now you will have higher inotropic effect, mainly you stimulate the alpha. So alpha receptors, when you're using dopamine, will not be stimulated until you go higher than 10 mics per kg per minute. And this is where you will get a vasopressor. Between 5 to 10, you have inotropic effect only. So look to this chart. It's very interesting, and you see, the effect of this medication for the dopamine receptors, and you see 0.3 mics per kg, 0.7, okay, and to 1, okay. And you see the activation in the renal bed or in the kidneys. You will see some dilatation, okay, and induced diuresis because there's a vasodilatation. Here you see when you go up to, you will see some increase in contractility and inotropic effect. When you go in the red here, you see stimulation of alpha receptors, and this will increase, the work of the heart, because you are increasing, systemic vascular resistance, you are vasoconstricting. And be mindful to this statement: increases heart rate could induce arrhythmias. Now, vasopressors, do you guys use vasopressors? Can you answer me? Do you use vasopressor in your emergency? I mean a sole vasopressor, not mean, other medication that could have both effects, but I'm talking about phenylephrine and vasopressin. Vasopressin. Do you use vasopressin and phenylephrine? Bina saying no. Other, do you have any input about using phenylephrine and vasopressor? No, yes, okay. Just so we'll cover this now, and maybe this is an idea how to use them later on, to be ready how to use them in the ER. So what are the choices? These are increase the blood pressure, mainly the MAP, which is we're looking for to make sure that we have at least a minimum perfusion that could supply the cells and the tissue with oxygen. Now, what are the choices? Norepinephrine, dopamine, epinephrine, phenylephrine, and vasopressin. These are called vasopressor. Now, as we said, some medication have mixed effects. We're talking about norepinephrine, dopamine, epinephrine. These having mixed effects. So it could have vasopressor effect. It could have, inotropic effect. It could have a vasodilatation effect. Okay, but when we're talking about phenylephrine and vasopressin, this medication purely alpha agonist. It does not cause any other, inotropic support. What are the complications? And this is, what we need to know. Principal use vasodilatory shock. So when the systemic vascular resistance fall and became low, you need something, and even if the cardiac muscle, the contractility is optimal, the flow of the blood in the arterial wall will get, slow, and it will not reach to the tissue and to the cells. So you need to press or squeeze the arteries to make sure that you are pushing the blood to the all tissues and cells. So how do we do this? We are, that's what we have in the sepsis vasodilatory shock. We're using the vasopressor just to compress, the arterial wall, the vessels. And so this will make sure that the blood will flow faster to the tissues and to the cells. Other use, cardiogenic shock, coronary perfusion, obstructive shock. And look at when we're talking about obstructive shock and hypovolemic shock, they are temporary. They are not, a permanent, fix for the problem. You have to fix, look for the issue, solve it. If it's a tamponade and your patient needs pericardiocentesis, okay, you need to prepare him for pericardiocentesis and do it, okay? But meanwhile, while you are preparing and you want to make sure that perfusion is maintained and, restored to the tissue, you start these vasopressor just to your stuff for chest tube in case of pneumothorax or pericardiocentesis in case of cardiac tamponade. Then after that, you treat your threatening hypotension. Even with a hypovolemic shock, patient presented to ER with massive bleed, or he has a post-trauma MVA, and he needs a hypotensive refractory shock because of his bleeding. You give him blood, you give him fluid, and the patient is not restoring his volume. So you need to buy a time before you take him to the theater. So you might start these medications just to make sure that you have some restoration of the blood volume in the body. Noradrenaline, or what we call it norepinephrine. This is a potent alpha-adrenergic agonist with limited beta-1. So as we said, they have mixed effects. So we're talking about norepinephrine. Norepinephrine is mainly potent with alpha, but it does have some, effect in beta-1. That means it's vasoconstrictive, and at the same time, it helps increase the cardiac output, the contractility, increase the heart rate for the patient. But this is a limited. So when you start, your patient norepinephrine, if he's tachycardic, you expect him to increase a little bit, but there's no much increase because they have a limited, receptors for beta-1. It does increase the MAP by vasoconstriction, small increase in the systemic vascular and, in the cardiac output. The dose is 0.01 to 3.3 mics per kg per minute. And you're targeting the MAP is to 65 to 90 millimeter mercury. That is the minimum to restore, patient, perfusion. Now, can we give this medication peripherally? Can you answer, please? Can we give this medication like norepinephrine peripherally? No, no, no. Abdulaziz said yes. No. So just, a small dose, excellent, Hussein. In a central line, prefer to have a central line, okay? But, if you can start this medication in a peripheral line, but it's gonna be different concentration, different, and lower doses. So if we are giving like, the normal, we put 12 milligram and 250. But when it comes to using peripheral, we will not put 12 milligram. We may use, 4 milligram only in a bag. So this is limited doses, lower doses for the peripheral. So if you are not using that, if you are, instant in your department, you're using only central, yes. Especially why we need it if your patient is in a septic shock or in a shock, any kind of shock, sometimes it's difficult to put a central line. Central line might take a time, okay? So peripheral line, it could be used to push this medication, but be mindful that, these medications are vesicant drugs. Vesicant drug. So when we mean vesicant drug, that this medication, if they get, infiltrated or extravasated under the skin, they might cause, as you see in this picture, tissue necrosis, okay, and some patient might go with amputation, gangrenous fingers. It does have potential decreased blood flow in insufficiently fluid resuscitation, okay? That means, you cannot start this medication if the patient has no volume. You make sure that your patient is volume-wise, okay? Volume-wise, that the patient is restored. So once you fill the tank, okay, use this medication so it can pump this fluid to the rest of the body. It has also effect in the renal, splenic, and peripheral. Okay, just give me a second. Let me check the voice, guys. Okay, guys. I'm hearing it's clear, good, excellent. The next drug is dopamine. Dopamine also a natural precursor of noradrenaline and adrenaline. Those, as we said, it's dose-dependent effect. So if it's less than 5 mics, it's more dopamine receptors, vasodilatation, renal bed and mesenteric. 5 to 10, that's, inotropic, and 10, more than 10, you're talking about alpha adrenergic effect vasopressor. It does increase in the mean arterial pressure, okay? It does increase in cardiac output to increase in the systemic vascular, and lesser in the extent in the heart rate. Renal dose, 2 mics per kg per minute. The downside for the dopamine, okay, it's a lymphocyte apoptosis, immunosuppression, okay, but the most important thing for us to know, it's more arrhythmic events in patients with a cardiogenic shock. So when it comes to the cardiogenic shock, your patient is already, the muscle is injured, giving, more beta receptors to be activated. This will cause arrhythmias. It could lead to the, later arrhythmia. And does also decrease prolactin release. Low dose dopamine and renal failure. This is, a study, the use of dopamine in acute renal failure, a meta-analysis, okay. The conclusion was, the use of low dose dopamine in the treatment or prevention of acute renal failure cannot be justified on the basis of available evidence and should be eliminated from routine clinical use. When it comes to between dopamine and norepinephrine in treatment of shock, which one is the first line to be used? The study, the trial included 1679 patients, of whom 858 were assigned to dopamine, and the rest were assigned to norepinephrine. Now, the study found out, okay, it was also dependent on the, compared with norepinephrine, increased rate of death, assessing the patient at 28 days. And they found that there was no significant difference in the rate of death between patients with a shock who were treated with dopamine as a first-line vasopressor agent and those who were treated with norepinephrine. The use of dopamine was associated with a great number of adverse events. So this is the study. When it comes to the, significance of the rate of the death, there was nothing, difference between dopamine and norepinephrine. However, there was more adverse event from the dopamine. As we said, because norepi, it has limited in beta 1. This is, it does activate or stimulate beta 1 more. Survival sepsis campaign, they recommend, to have MAP, okay, above 65 millimeter mercury. They recommended either norepinephrine or dopamine as a fair choice of vasopressor agent to correct hypertension and septic shock. They suggest that epinephrine, phenylephrine, or vasopressin, these are, should not be administered at the initial vasopressin and septic shock. Vasopressin on 0.03 units per minute may be used subsequently added to norepinephrine with anticipation effect of equivalent to norepinephrine alone. So if your patient is having refractory hypertension with one, vasopressor like norepinephrine, you might, mix another vasopressor like vasopressin and started with the patient just to lower the dose of norepinephrine and to buy time for the body be responsive to the norepinephrine. They suggest that epinephrine be the first chosen alternative agent in septic shock that is poorly responsive to norepinephrine and dopamine. Guys, do you know what type of car this is? Any idea? Nobody dream about a car like this? Al-Hanouf, she wants to have a Bugatti. Who's this? Okay, excellent, excellent. No, Abdulaziz, this is not Toyota. This is not Camry. Okay. So who can tell me, what is the biggest, advantage of this car? What is, why people they love this car? Oh, Maher, speed. Not luxury, speed. Very fast. Excellent, Hussein. Fastest car in the air. Excellent. So what this has to do with our lecture? Who can tell me? Speed, yes. There is one medication that can we use it is like Bugatti. This medication is faster medication. It has amazing adrenaline. Yes, Haya, thank you very much. adrenaline. It's a potent alpha beta adrenergic agonist effect. Increased MAP, increased cardiac output, increased peripheral vascular tone, increased oxygen delivery. So what else we need? This is better than Bugatti. So if you want Bugatti, just buy a vial of adrenaline, and it's better than Bugatti. It's faster than Bugatti. So what's the downside for this adrenaline? It does the same thing about, norepi, or it does decrease the regional flow to the splenic, gastric, peripheral, and ischemia extremities. Increase the heart rate, potential induced tachyarrhythmia. That's one of the downside and big complication for epinephrine. Induce hypoglycemia, increase lactic concentration. Phenylephrine, yesterday we talked about, the intubation, RSI, and we talk about the difficult intubation. Let's come to the intubation. When we do intubation for the patient, one of the medications that used as about rapid sequence intubation is the phenylephrine, because medication, all of this medication has a downside, causing, transient hypotension. So nowadays, all the anesthetists, ICU, they prefer to, and emergency, they prefer to have, phenylephrine at the bedside. It can be given as a bolus to the patient just to improve the blood pressure. It's a pure alpha agonist, okay? It does increase, Yes, epinephrine and adrenaline are the same synonyms. We're talking about phenylephrine, pure alpha agonist, rapid onset, short duration, primary vascular effect. Second line septic shock. It is not the first line, but you will see it. Sometimes they use it, especially if your patient became very tachycardic. This medication does not affect the heart rate. Spinal shock indicated in the spinal shock. Vasoplasia after cardiac bypass, and this is what we talk, medication-induced hypotension. Example of that, rapid sequence intubation, which should be part of this and should be available to give for the patients. Vasopressin, that's centralized in the hypothalamus, stored in the pituitary gland. It's a hormone released in response to decreased blood volume, decreased intravascular volume, increased plasma osmolality. What is the effect of vasopressin? Constrict vascular smooth muscle via V1 receptors, increase responsiveness to catecholamines, and that's why they use it in conjunction with norepinephrine, because if the patient is not responding to the norepi, they add vasopressin, and this will increase the responsiveness for the catecholamines medication, whether epinephrine or norepinephrine. Inhibition of vascular smooth muscle, NA production, and potassium and ATP channels. How to use it? Is 0.3 unit, as we said, per minute added to the norepinephrine. Appears to be safer and effective as norepinephrine fluid resuscitation patient with septic shock, and maybe more effective with patient with lower doses, to lower. And this is, as we said, we need to lower doses or increase the responsiveness to the norepinephrine. We add vasopressin. Should not be thought as a replacement therapy in relative deficiency rather than a vasopressor agent to be titrated effect, and should be used only for low doses and should be only for 48 hours as a bridge, so you are not continually giving this medication. What are the complications of vasopressors? Okay. Complication of vasopressor is tachycardia and tachyarrhythmias, myocardial ischemia and infarction. Okay. Coronary artery constriction, as we said, it decreases blood flow to the coronaries, decreases stroke volume, presence of myocardial dysfunction, decreased oxygen delivery, limb ischemia, necrosis, impaired blood flow to the splenic bed, stress ulceration, ileus malabsorption, absorption, bowel infarction. Many complications could happen from these vasopressors. So you are not aiming to go with the higher doses. The higher doses you go with this medication, the more complication for the patients, okay? So you need to be judgmental, you need to be logical when you use this medication. These medications are a harmful medication for the patient. You should use them wisely just to restore, over a period of time, by time, solve the issue of the patient. If it's infection, if it's, bleeding, if it's, cardiac muscle, solve it, okay, as soon as possible with the treatment, and by sometimes, just to try to wean this medication as soon as possible. So now you might be a little bit confused. Okay, what medication should we use then? Which one is the best? The principles, improving the myocardial contractility. Monitor your cardiac output as a substitute for contractility, easier and more relevant. Now, if you do have this, modalities to do that in emergency or in ICU, like swan scans, PICO, Vigilio, TEE, all of this, you can monitor the cardiac output. Increasing cardiac output to determine subnormal level in the patient, not to improve outcome. And this is what we told. You need to have the minimal outcome cardiac output that helps in, only to save restoration of the blood supply to the tissue. I'm not aiming to bring the patient to the normal, phase. It's only to the minimal. Now, dobutamine, predominant beta-1 adrenergic effects, positive inotropic effect, positive chronotropic effects, initial agent choice for cardiogenic shock. Why? Because it's have a positive inotropic and chronotropic effect. Have increased myocardial, oxygen consumption, initial agent choice of septic shock with low cardiac output and adequate filling pressure, small group. Phosphodiesterase inhibitors. These medications increase intercellular independent of beta receptors, inotropic effect. It has inotropic effect, fewer chronotropic and arrhythmogenic effect. The most important, the famous one is milrinone, that is used more potent pulmonary vasodilator, and then the dobutamine, so it's often preferred in case of predominant and the right heart failure, patient with end-stage heart. Yes, Ahmed, it's like dobutamine, but it's more because it does have a pulmonary vasodilator. It's more effective, more used in the stage heart failure with the right heart failure patient. So patients with pulmonary hypertension, they are always in medication like phosphodiesterase inhibitors just to dilate the pulmonary artery. Calcium sanitizers. This medication increase the cardiac myocyte calcium responsiveness and no increase in the myocardial oxygen using the cardiogenic and septic shock. It does have inotropic effect and vasodilator properties. So I want you just to take a minute, okay, and if you can see the screen, take a shot, okay, and from this screen, and this is, it could be, the summary or the conclusion or the message I want you to take home today with you. So these are the list of the medication with their doses, okay, And these are the effects they have in the heart rate, in the contractility, in the vasoconstriction, in vasodilatation, and in the dopaminergic effect. So if you're looking to the epinephrine here, the Bugatti one, okay, you can see he has plus, 4 effect on the heart rate. So it does have cause tachycardia. In the contractility, it does cause contractility. In the vasoconstriction, it does also vasoconstriction. It does also vasodilatation effect, but no dopaminergic effect. Look at the Myrionone example, okay? Small effect on the heart rate, contractility, okay? +3, and vasodilation is +2, and has no effect in vasoconstriction. So you're not expect your patient to have increase in the heart and blood pressure with patient in Myrionone. It could be normal. It could be mainly with the vasodilatation. You expect the blood to go. So it's a variable, for the blood pressure. For patients who are vasopressin example, you see that is mainly vasoconstricted. No effect in vasodilatation, no effect in contractility, no effect in heart rate, okay? And go to the norepinephrine, it's the same, okay, like vasopressin. However, vasopressin is more potent when it comes to the vasoconstriction. So please take a shot, a photo for this one and keep it with you. How we can success, how we can choose the best one, how we can treat the patient safely if he needs this. So the key to success is identify the etiology and pathogenesis of the shock and adapt and treat. As we said, we need to be logical. We need to be, when we think about treating the patient is very sick, critically ill. You are not aiming to bring him back to the baseline. In no way you can bring him back to the baseline. You want, to have some optimal result that will be later on. But at the beginning, you're just aiming to restore a minimal, circulation or perfusion to the patients that make sure that the tissue and cells are, having some sort of perfusion. Choose the vasoactive agent in context of goal therapy. Set ultimate goals of the therapy. And this is what we call the ultimate goals that should be, at the end of your treatment. Restore effective tissue perfusion for all tissues. You have to think about the skin, the gut, you have to think about the kidneys, you have to think about all organs. So you are not, aiming to, to restore, blood pressure, okay, and make sure blood pressure is okay, and while, the patient having acute kidney injury. So you need to look at the patient as one unit and to choose medication that will help you, because if the kidneys start, to fail, for sure the patient, will deteriorate more. So we need to balance, and this is, this is the message that you need to go to take it home. You guys, you can hear me? Okay, excellent. So I'll speak a little bit in Arabic. Okay. الرسالة أو لازم توصلوها اليوم إنه هذا الدواء الأدوية تستخدم في حالة الطوارئ. لازم تكون الشخص الذي يستخدمه سواء طبيب ولا ICU ولا طوارئ لازم يكون نفكر في موضوع إنه هذا الأدوية ممكن تأثر على أعضاء ثانية بالجسم. فأنا ما عندي مشكلة إن يكون blood pressure low، أوكي، as long as إنه والله perfusion is okay. فأنت ما بدك تعمل للمريض مثلاً إنك تسوي تضبط ضغطه من هون وتخرب عنده الكلى أو يصير عنده مشكلة في الرئة أو يصير عنده مشكلة في مكان ثاني. You need to be having sort of balance. هناك توازن في عملية إعطاء الدواء. لا تعطي الدواء كثير كمية كبيرة، تختار نوعية الدواء الصح اللي مناسبة لحالة المريض، بحيث إنه أنت ما تعمل another injury to the patient. And you monitor the parameter of tissue perfusion and cellular metabolism. Frequent VBGs, frequent lactate labs to make sure that this, urine output. I will talk about this in clinical and non-clinical parameters. So what are the parameters of tissue perfusion, cellular metabolism? If you're looking for clinically, you're looking for, level of consciousness of your patient, cab refill of your patients, skin should be warm, change the color of the skin, pulses should be, more stronger, lactate, And if you're doing it directly, this is, going to be more technical, where you're having, gastric mucosal pH, gastric mucosal PCO2, sublingual circulation, and sublingual capnometry. And these are very advanced. This is all about, the vasoactive, vasopressor, anaerobic medication that can be used in case of a very sick patient. Any question? I'll give you like 2 minutes. If you have any questions, please. Okay, guys, if you have no questions, you can take like, 10 minutes break. Sorry, 5 minutes. Take 5 minutes till we prepare for the next session. So 3 minutes will start for the next session. Thank you very much.
Good morning everyone. السلام عليكم. Can you hear me? ممكن تسمعوني بشكل كويس لو سمحتوا؟ Good morning. السلام عليكم. اوكي. نبتدي الحين بالمحاضرة الثانية واللي هي مثل ما قلنا بالجدول It's the acute stroke. كمان نحن عم نحكي عن الاشياء العالقة مثل ما شفتوا محاضرات العالقة بالامرجنسي، محاضرات العالقة بالكريتيكال كير، والحين حنحكي عن سيشن It's very important اللي بتتكلم على قصة الستروك. And in this session بهذه المحاضرة حنتكلم بشكل كثير كبير. أول شيء بعطيكم فكرة عن قديش في حالات التجلط أو stroke around the world to see how much our people are suffering with this stroke. أول شغلة every 40 seconds we have one person in the United States has a heart attack. And we have every year around 7,000, 90,000 Americans have a heart attack. About 7,095 million people in the United States have a stroke every year. As you see, it's a big number to people having a stroke per year. The stroke, it's one of the leading cause of death in the United States and everywhere. إذا مثل ما شفتوا أهمية الستروك إنه في عدد كبير من البوبوليشن من الناس هن already بيعانوا من موضوع الستروك التجلط الدماغي، وهن the number it's a big number and we gave you example already from the United States. أعطيناكم example قديش عدد الحالات قديش عدد الناس بيصير عندهم التجلط. وبذات الوقت شفتوا it's one of the major fifth leading causes، يعني هو من الأسباب الأساسية اللي عم بتسبب الوفاة بالولايات المتحدة نتيجة الستروك. نحن قلنا لكم تشوفوا شو أسباب الوفاة أو شو تتعرفوا قديش أهمية الستروك وقديش في ناس عنا يعني they have a stroke and they are at high risk to pass away. إذا بنبلش بقصة الهارت ديزيز came first followed by يعني أكثر عدد وفيات بالكرة الأرضية بالعالم هي من heart disease. السبب الأول. السبب الثاني بيجي قصة الكانسر. السبب الثالث بيجي قصة الأكسيدنت unintentional injury والسبب مثل ما شفتوا الكرونيك lower respiratory disease والسبب الخامس بتشوفوا اسمه stroke or cerebrovascular disease. فإذا مثل ما شفتوا هيدي أكثر سبب للوفيات بالعالم وشفتوا الستروك بيجي بالمرتبة الخامسة which is not small. مثلا إذا أنا what call my attention here إذا بشوف مثلا الديابيتس هي عدد كبير من الناس بتشوف الستروك سبب الوفيات بسببها اللي هي it's too much. Let me first I would like to start with a case scenario. أعطيكم حالة لمريضة case scenario and to see what are the cause of the stroke. شو سبب الستروك أو شو الحالة. You are visiting your 65 years old on your off day. انتوا رحتوا تشوفوا او تزوروا حدا من قرايبكم او جدتكم او الى اخره، هي عمرها 65 سنه، وهيدي هالشخص هو she's well known as a healthy person. She is healthy person. As she is a healthy person, there is no problem at all. No problem with her at all. ما في أي أمراض ولا في أي شيء. And she has some history of dyslipidemia. شوية الدهون عالية عندها and maintain on medication. فإذا nothing to be worried. 65 سنة. She's feeling well. No problem at all. She is healthy and she has a history of dyslipidemia but is sustained with medication, which is all of us, including me, and I have dyslipidemia with medication. There is no problem up to this moment. There is no problem at all. But while making some coffee, بينما كانت عم تسوي لكم القهوة, she fell or suddenly she became confused. فجأة صارت عم بتضيع الموضوع. يعني she lost her balance and she couldn't clearly talk and explain what is happening with her. فاذا فجاه لحديت كان كل شيء اوكي، ما في عندنا اي مشاكل، فجاه صار ضيع بالموضوع وشي لوست هير بالانس، بطل فيها يعني البالانس تبعها كمان شي لوست هير بالانس، بطل فيها يعني ما عرف فيها توازي حالها هي واقفه، حتى بطلت فيها تتكلم بشكل واضح او حتى تشرح شو عم بيصير معها. فاذا what do you think we are talking here about what do you think what happened to this person, what happened to her that suddenly this is what happened to her? How would you diagnose this person that suddenly she became confused, she lost her balance, she couldn't talk and she couldn't explain what happened with her? This is a stroke, but we need more details for sure. The details are coming. Details are coming. This is just introduction, maybe, okay? هذا just introduction رح نعطيكم بشكل مفصل عن هذا. فإذا this is a stroke. Exactly. طيب. You sat her down and gave her some cold water, but she couldn't even swallow. شوف لوين صارت، إنه حتى طلبتوا منها تجلس و you settle her and you give her water وعطيتوها water, but للأسف حتى ما كانت عم تقدر تبلع من الووتر. What do you think it happened and how you could, as healthcare practitioner, going to help your beloved one? My question, do you think what happened? Most of you answered that is a stroke. Now I'm asking you how, as healthcare practitioner, you could help your beloved one. Cold ambulance, dysphagia, slurred speech from stroke. Okay, but now I'm asking you how you could help her. حدا بيقول لي انه you will call the ambulance. What else? شو غير؟ We will call the ambulance. هذا مطلوب. Check be fast ABC. Call ambulance. What you are going to do? This is the aim, or this is the objectives of our session that we are going to start now. This is, for example, the diagnosis, as you said. This is an acute stroke. This is what happened to her. This is acute stroke. Now, how are we going to? This is in this session. For example, we are going to give definition about the stroke, the clinical presentation, what are the types of stroke, goals of stroke care, chain of survival, the 8 Ds of stroke, and this, if there is any special consideration. As definition, how we could define this stroke. This is a neurological deficit attributed to an acute focal injury to the system nervous center by a vascular causes. For example, we have intracerebral hemorrhage due to cerebral infarction due to intracerebral hemorrhage. It's a major cause of disability and death worldwide, as we mentioned. And this is the case is a stroke. It's one of the neurological deficit, and it's one of the leading cause of this. Now, as we said here, I will go to the previous slide that there is a disability. Okay. Now, did you heard about the TIA and what are the difference between TIA and the stroke? What are the difference between the transient ischemic attack and stroke? Any ideas? Thank you, Kinda. The TIA, it will goes away. There is no disability. Thank you, Abdullah. ممتازين صراحة جروب مميز. it will go without a treatment. It's not a life-threatening. Can you? The IA is reversible. Thank you. No disability. Excellent. فإذا what are the difference؟ نحن حكينا وقت المريض بيصير في عنده stroke سواء ischemic or hemorrhagic رح يصير في complication which is disability. On the TIA, it's a brief episode of neurological dysfunction. It's not for a long time. It's a brief one, resulting from a focal cerebral ischemia. It's acute for sure. It's not associated with permanent cerebral infarction. إذا أنا ما بكون في عندي permanent لأنه وقت بصير في عندي permanent cerebral infarction, it's caused by the stroke. Stroke will be subject to permanent cerebral infarction. Now, how do you know, Mr. Zainab? Mr. Zainab, I will tell you. How you know? It will come briefly suddenly and it will go suddenly. ما بيصير في عندنا أي disability للمريض تجي during a period of time and it will go after a while for a period of time. بينما الستروك it will come رح يكون في disability رح نشوفها. It might be kind of hemiplegia and other signs and symptoms that you will do. So this is the difference that it will resolve كمان TIA يا أخت زينب هي بتروح خلال ساعة بينما الستروك بالأخص إن المريض المسكين بيكون عنده ستروك بعمر صغير it might stay for the life. بالكل بيصير فيه يعمله just to improve the quality of life إنه يقدر يتحرك أكثر وإلى آخره rehabilitation but خلاص it's like مثل مرضى السكر وقت بصير مرضى السكر خلاص it will be very hard just it's there is no treatment. كمان TIA or stroke ما بيكون في treatment to improve the quality of life. And here this is the one. فإذا TIA it will go spontaneously within 1 hour. خلال ساعة it will be solved. طيب it's clear يا أخت زينب؟ وضحت بالنسبة لك الصورة؟ Now what are the types of stroke؟ فإذا نحن عندنا نوعين من التجلط stroke. في عندنا بنسميها الاسكيميك ستروك والهيموراجيك ستروك. فإذا في عندنا نوعين اللي هو الاسكيميك واللي هو الهيموراجيك. حسب رأيكم شو السبب؟ If you will see here إذا بنشوف على الاسكيميك مثل ما شفتوا هون there is kind of ischemia في تسكير للشرايين اللي عم تغذي الرأس بينما هون في rupture. This is a difference. طيب بحسب رأيكم شو what are the leading cause that it cause ischemic stroke وشو السبب اللي بيسبب الهيموراجيك ستروك؟ hypoxia or bleeding. ليش بيصير في عندنا hypoxia or bleeding يا أخت بهية؟ ليش الهايبوكسيا شو بتسبب والبليدنج شو بتسبب؟ dyslipidemia and embolism. Thank you أستاذ عبد الله. فإذا dyslipidemia هي شو بتسبب يا أستاذ عبد الله؟ بتسبب الاسكيميك ستروك، مضبوط؟ بينما الهيموراجيك نتيجة شو؟ نتيجة الهايبرتنشن. ثانك يو كيندا. فإذا بتشوفوا إنه نحن الشغله اللي ما بتقولوا وقت حدا بيقولوا له حتى لو ما كنا بالفيلد الميديكال تعرفوا إنه بيقولوا take care of your blood pressure لأنه مجرد ما يعلى ضغطك بيصير في عندك انت ستروك. يعني هاي اللي بيقولوها الناس كلهم بيقولوا انتبه ما تنجلط، مضبوط ولا لا؟ بي كيرفل يو مايت بيصير في عندك تجلط لانه وقت بيعلى الضغط بشكل كثير ضغط الدم بشكل كثير كبير that it might be it might cause the hemorrhage. اذا بتلاحظوا انه السبب مش كل المرضى يعني ليش ما بيصير في عندنا حسب رايكم اسكيميك ستروك اكثر من هيموريج؟ لانه الاسكيميك ستروك الهيموريجيك ستروك يعني وي كود كنترول يعني باي ناحيه انه نحن البلاد بريشر وقت بنعرف انه هذا هاي بلاد بريشر مش دغري على طول بصير في عندنا تجلط unless اذا صار في هايبرتنشن بشكل كثير كبير. نحن وقت بيكون في عندنا هايبرتنشن او بلاد بريشر نحن بهالحاله we could control it through medication. مشان هيك مرضى الضغط اجمالا بيكون عندهم medication. And if you control your medication you will avoid your stroke. إذا بتخفف الستريس بتخفف الديسليبيديميا you will eat healthy بتعمل حركة ورياضة وإلى آخره you will take medication on time you could avoid the hemorrhagic stroke. أوكي فإذا 87% من الحالات هن ischemic stroke and 13% only it's a hemorrhagic stroke. Now خلينا نشوف what are the clinical presentation. يعني أنت المريض شو هي أو المريض شو هي الكلينيكال برزنتيشن اللي بتبين عن مريض الستروك or how a stroke patient he will present. أول شيء بيصير في عنده مثل ما اتكلمنا، إذا بنرجع على الكيس سيناريوز اللي حكيناها قبل بتشوفوا إنه أول شغلة بينت هي قصة الهدك. فجأة suddenly بيصير في عندكم، مشان هيك بنقول لكم وقت تكون عندك هدك first question will ask you what. أي مريض بيصير في عنده هدك شو بنقول له أول شيء؟ شو تسوي؟ طبعا related testation عم نحكي. إذا مريض عنده هدك what we will advise him first. Check your blood pressure always لأنه high blood pressure it might cause headache. إذا صار في كثير blood pressure عالي بيصير في عنا bleeding and this is cause of the hemorrhagic stroke. طيب ثاني شغلة بده يصير في confusion. This is since it's a neurological deficit and it's a neurological problem اللي هي stroke it might have كل شيء neurological problem رح يصير في عنا علامات اللي بتكتب neurological symptoms اللي هي مثلا confusion، الابnormal vision والabnormal speech مثل ما صار مع الكيس اللي حكينا عنه and it will have a weakness and numbness on one side of your body. يعني إذا أنتم حسيتوا إذا صار في عندكم ستروك على جهة اليسار رح يصير في عندنا الويكنس والنمبنس على جهة اليمين، والعكس الصحيح. إذا صار في عندنا الموضوع على جهة اليمين رح يصير في عندنا الويكنس والنمبنس على جهة اليسار. كمان you will lose your balance مثل ما شفنا بالكيس سيناريوز اللي قبل إنه she lose her balance and inability to walk. يبطل فيها شخص يمشي. As per AHA American في شغلة you need to memorize it هي كلمة fast. What do you mean؟ كيف تعرفوا المريض؟ إذا سألتكم what are the signs and symptoms of in my message to you، إذا سألتكم أو سئلتوا أو حطيتوا بالسيتويشن مريض عنده stroke or he's at high risk and what كيف بتعرفوا؟ من خلال كلمة fast FAST and this is how are we going to manage our patient or Cincinnati. نحن بنشوف عندنا الفاست اللي هو ال F came from face or dropping, R weakness, speech difficulty and time which is very important and you will see it now. أول شغلة اللي هي مثل ما حكينا بقصة الأربع سنين اللي هي الفاست. This is what we call or the Cincinnati or the pre-hospital stroke scale. أنا Cincinnati or pre-hospital stroke scale. هودي الأشياء اللي لازم نعرفها. كيف بتلاحظوا عند المريض إنه صار في عنده ستروك؟ أول شغلة الفيشل دروب. بنشوف إنه شو الفرق بين هون والهون؟ What are the difference between the first picture and the second one? If you take مثل ما تتذكروا كلمة fast or Cincinnati or the fast. Let's see the first picture which is number 1 and number 2. What are the difference؟ تعبير الوجه. يعني بنشوف هون in the first picture what we could see that this is what called the face dropping. Here it's normal because the both sides of the face move equally. ما في عندي أي مشكلة. بينما إذا بنشوف here in the second one side of the face does not move as well as the other side. يعني أنت بتشوفوا إنه هون تعبير الوجه هون there is no problem. The both sides could move equally, no problem at all. If you will compare to the second one, there is one side is moving and the other one is not moving at all. This is the when you will go back about the face or the first part. Okay, this is clear. Second one will be the arm. The second one will be according to our neurological September and during our GSA in July, it's be fast instead of fast. Recently added to balance. Okay, thank you for your extra information, dear. And this is the good things in the symposium that we will hear to learn from each other. طيب. فإذا نحن عندنا هون what are the difference between these two? We have the arm drift now, and how are we going to test this? We will ask the patient to close the eyes first and to hold the both arms for 10 seconds. فنطلب من المريض انه يسكر عينيه ما يطلع، وبنطلب منه انه just to يعلي اليدين لمده 10 ثواني. طيب, what will happen now? The first one, what will happen if it's normal? The both arms move the same or both arms do not move at all. فإذا الإيدين يا بيتحركوا مع بعضهم يا ما بيتحركوا. الابنورمال بنشوف انه one arm does not work or drift down compared to the other one. Second one بنشوف انه المريض نحن مثل ما طلبنا للمريض انه يغمض عينيه لمده 10 ثواني to hold his arm. شو صار؟ abnormal he could hold it, no problem. Abnormal he could hold one hand and the other one it will drift down. This is the second one of the فإذا قلنا عن الفاست. الأول هي الفيشل والثاني هي الأكين from arm. The third one, which is the abnormal speech, and you will ask the patient to say one sentence or one word or one paragraph, and you will see if he could speeches, if he has observed speech or he could talk properly. Now you could ask him just, you would ask the patient to say, you can teach an old dog a new tricks. Now, if the patient, how we could classify the patient as normal, if he will say that the patient uses correct word with no slurring. بيقول لك إياها بشكل كويس ما بغلط. You can teach an old dog new tricks. بيقولها مثل ما هي لا بالزايد ولا بالناقص. الابنورمال يصير في عنده slurred word، ممكن يستعمل كلمات خطأ أو حتى بيكون ممكن ما يقدر يقول الجملة مثل ما هي. أنتوا لاحظتوا وقت أعطينا السيناريو أول شيء تبع اللي راحوا زارت جدتها كان كل شيء نورمال صدقني شي لوس بالانس وما قدرت تاكل وما قدرت تعمل الصورة والحط. هون نفس الخبرية فجأة بصير هالمريض ممكن نطلب منه انه ثلاث كلمات ممكن اذا قالهم بشكل كويس اتس اوكي، ما قالوا ممكن ما يقولون وممكن يقول كلمات غلط. This is what we call the abnormal speech. This is the third one. فاذا حكينا عن الاف اللي هي الفيس، حكينا عن الار اللي هي الويكنس، وحكينا عن الاس اللي هي السبيتش. كلير؟ اي سؤال بالنسبه للموضوع؟ شكرا لكم. يعطيكم ألف عافية. Now, for you to know إذا كان عندي one of these three signs is abnormal, the probability of stroke is 72%. إذا كان عندي، فإذا رح أحكيكم على حديث هلا صرنا عن الفاست. إذا كان عندي وحدة من هول الثلاثة abnormal، يعني شو هذا بيعني؟ إنه المريض 72% هو مريض ستروك. إذا كانوا 3 signs اللي هي الفيشل دروب والارم دريفت والابنورمال سبيتش abnormal، هذا المريض 85% he is a stroke patient. طيب هون نحن عم نحكي على شغله جدا مهمه. Timing, it's very important to save the brain and to avoid the complication and to avoid the stroke if the patient start having signs and symptoms of stroke. فإذا مثل ما حكينا عن قصة الكاردياك والنيورو والى آخره، قصة التايمينج for the heart it's very important. قصة الوقت هي شغلة جدا مهمة منشان just to save the life of the patient. فإذا as you see here in a typical acute ischemic stroke every minute until reperfusion or the brain. رح تشوف قديش إذا شغلة منشان reperfusion it's very important. فإذا the brain شوفوا لحديت يعني قديش مهم لحديت ينعمل ريبرفيوجن we will lose 1.9 million of neurons, 14 billion on synapses, and 7.5 of fibers. Now, moving, فإذا خلصنا الديفينيشن أعطيناكم إياها، الساينس and symptoms أعطيناها، رح نشوف هلا how to care for a patient with stroke. How we could take care for a patient with a stroke. هذه الشغلة فإذا هذه بنسميها اللي هي قصة ال 8 Ds. فإذا مثل ما تكلمنا, this is how we are going to take care of our stroke patient. Remember the 8 Ds اللي هي detection, dispatch, delivery, door, data, decision, drug, and disposition. هذا ال 8 Ds that we are going to talk about. أول شيء إذا نشوف على detection تكلمنا عنها how we are going to detect or detection of the stroke symptoms. تكلمنا عنها حوالي نص ساعة صرنا نتكلم على نفس الموضوع هي detection مثل ما حكينا اللي هي السنسيناتي واللي هي الفاست. بس مطلوب منكم تذكروا كلمة سنسيناتي وفاست بالديتكشن اللي هي بتعطيكم فكرة عن الديتكشن. يعني كيف تعرفوا انه المريض هو is a stroke patient through signs and symptoms اللي تكلمنا عنه. dispatch مثل ما تكلمنا أهم شيء بكل شيء just يعني احفظوها غيبا مثل ما بنحكي. أهم شيء بكل شيء اسمه emergency هو التايمينج. نحن كل ما سرعنا بالتايمينج كل ما صار هالموضوع كل ما you will save the life and you will save the complication. يعني مش بس you will save the life مش بس لأنه نحن في ممكن نودي المريض لكومبليكيشن يضل يعاني منها كل عمره. وقصة الستروك هي شغلة جدا مهمة. كل ما عملنا ريبرفيوجن ظبطنا الموضوع كل ما المريض يصير يعني we will complain. فإذا قصة الديتكشن مهم. ما قاعد اتحذر أنا الساينس and symptoms مجرد ما عندي المريض هذه العلامات خلص what should be done first. مثل ما تكلمت تفضلتوا قلتوا لي إنه I need to call the ambulance. أنا بتكلم الأمبيولانس 911 منشان just to take the patient and send the patient to the nearest stroke center. أنتم بتعرفوا في بالأخص في مراكز مخصصة للستروك أو the nearest emergency. مش كل الأماكن فيها stroke center but mainly يعني بيفضل إنه يكون لأنه هو مكان مجهز منشان هذا الموضوع. فاذا بالدليفري كمان وقت المريض since you identify الامبيولانس نحن عندنا مريض with stroke this is يعني we will have a rapid EMS identification management and the transport. نحن ال EMS they need identify بنبلش المانجمنت من اهم شيء يروح على المستشفى او على ستروك سنتر في اسرع وقت ممكن. يعني والمانجمنت دائما بتبلش من يعني من الامبيولانس ما ننطر مريض لحتشوف شو في المانجمنت. فاذا نحن وقت بنعمل we will call 911 نحن بنبلغ المستشفى انه we are sending a stroke patient. شغله جدا مهمه ما بنترك الموضوع انه لا لانه بعضهم يكونوا جاهزين لانه we need to prepare the management. لانه وقت يكون في to call this stroke team. في كثير من المستشفيات we have a stroke team. I don't know if in your hospital if you have a stroke team, but mainly we need to have a stroke team. الدور appropriate triage مثل ما تكلمنا امبارح كثير عن الترياج. فإذا كمان وقت المريض بيجي we need to do a triage for the patient in the stroke center or in the hospital. Data بنرجع للداتا اللي we collected from the patient that we need to go to the hospital. And the decision مثل ما حكينا بيكون في stroke team اللي هي this is the one اللي هو مكون من الأطباء والآخره. This is the one just to start the management of the stroke patient. والدراج رح نحكي عنها the proper treatment or the proper line of treatment for the stroke patient هي fibrinolytics والintra arterial strategies. وبعدين بعد ما نعطي الدراج the patient he needs to be admitted to the ICU or to the stroke unit for further investigation and for management. فإذا هذا بنسميهم ال 8 Ds اللي هم المفروض يكونوا موجودين. We need to do it, we need to follow it منشان نخفف عن المريض. وأهم شيء مثل ما حكيت لكم in addition قصة الداس اللي نحكي عنها بكل الإمرجنسي قصة to avoid the complication لانه it's a long life complication ممكن يكون عند مريض الستروك. Any question regarding the 8Ds؟ في شيء مش واضح بالنسبه لل 8Ds for stroke care؟ عظيم. نحن وقتها مثل ما قلت لكم المريض we need to take it to the stroke center. في وكلمتكم على قصه التايم مانجمنت، كيف how we manage the time، كيف نعمل مانجمنت للتايم عند المريض. نحن التايم اللي بتفوز شغله جدا مهمه. اهم الشغله وقت احكي لكم عن التايم كمان بيتقسم. يعني اول شغله I have 10 minutes to do a immediate general assessment. يعني عم بحكي لكم انا من وقت المريض بيكون بالبيت لوقت اللي بيكون خلص بالستروك يونت او بالاي سي يو او باليونت. واضحه؟ هيدا الوقت اللي المفروض انا امشي فيه. فاذا هيدا الوقت اللي المفروض انا امشي فيه. اول شغله اللي هي immediate general assessment it needs to take up to خلال 10 دقائق انا المفروض يكون الموضوع انتهى عندي. عملت general assessment للمريض اللي صار في عنده اي شيء غير general assessment. second one neurological assessment. بدي اعمل انا شو neurological يعني حسب رايكم شو neurological assessment that it should be done. برجع بقول لكم مش after 25 minutes، يعني لحديت يعني هون نفهم انه انا معي 25 دقيقه تكون عملت جنرال اسسمنت ونيورولوجيكال اسسمنت، مش 10 دقائق. انتبهوا، مش 10 دقائق للجنرال اسسمنت و25 دقيقه بفول نو including 35 minutes منشان تكون معمول جنرال اسسمنت ونيورولوجيكال اسسمنت. ما تختلط الموضوع. المعلومه جدا جدا مهمه. نحن اهم شيء واهم انترفنشن واهم عمل لمريض ستروك انه اعمل سي تي سكانر. انا بدي اشوف why do you think I need to know to do that CT scanner. وستيل برجع بقول لكم السي تي سكانر it's a part of the neurological assessment. Do you think why do we need to do a CT scanner? since المريض عنده ستروك ونعرف انه ستروك، ليش انا بدي اعرف ليش بدي اعمل السي تي سكانر or CT brain to rule out the bleeding. Thank you استاذ ماهر. Thank you خبهية. type of stroke. Thank you. تعرف أنا كيف بدي أعرف إذا نيورولوجيكال؟ لأنه هاي شغلة جدا مهمة اللي قلت عنها الأخت بهية، لأنه بشوف التايبس، لأنه كل تايبس له علاج. أنا ما في أعطي إذا مريض عنده هيموراجيك أعطي الفايبرونوليتكس يعني تختلف. أوكي، فرق ما يكون عندي أنا bleeding، فرق ما يكون عندي blood clotting. It's two different treatment, two different line of treatment. مشان هيك اهم شيء انا اعمل مشان اعمل السيتي سكانر. كمان معي لحديت ال 45 دقيقه مشان اعمل انتربريتيشن. يعني اللي بنفهم منها انه انا معي لحديت على 45 دقيقه مشان اعمل جنرال اسسمنت، نيورولوجيكال اسسمنت، اعمل سيتي برين واقرا نتيجه السيتي برين. ما في اعمل سيتي برين اقول يلا نتيجته بعد 3 ساعات، لانه انا هذه نقطه مفصليه هون. ما في يكمل انا ما في اعطي العلاج الا ما يكون عندي النتيجه. جدا هذه معلومات جدا مهمه. ما بقول انه انا اوكي عملت السيتي برين وخلاص ممكن ستارت اللاين اوف تريتمنت. لا، انا كله موقف، كل التريتمنت او كل العلاج موقف على الانتربريتيشن اوف سيتي برين. اذا ما عملت انتربريتيشن انا ما في اعطي الميديكيشن. then based on the result of the CT scanner انا I have ischemic of hemorrhage. اذا اسكيميك انا بروح على الفايبرونوليتكس ثيرابي اللي هي بتنعطى بالطوارئ. كمان في انديكيشن انه ما في يعطيها كيف مثل هاف وي ويل سي ات ناو. طيب، فاذا administration 30 minutes administration of fibrinolytic therapy time from ED administration of fibrolytic therapy time from the onset of symptoms. انتبهوا يعني أنا برجع بقول لكم كمان جدا مهمة fibrolytic therapy معي أنا لحديت الساعة فمشان يكون انعطى، ومعي حديت 3 ساعات من الوقت اللي ببلش العوارض. يعني كيف يعني إذا المريض صار في عنده اليوم هلا الساعة نحن الحين الساعة لنقول 49 دقيقة، لحديت أي وقت مفروض أنا أعطي الفايبرونوليتكس. أنا خدت المريض على الطوارئ الحين، هلا مشينا الحين على الطوارئ، معي لحديت الساعة لأي ساعة؟ معي لحديت الساعة 10 و40 دقيقة مشان ينعطى الفايبرونوليتكس، ومعي لحديت الساعة 11 ونص 12 تقريبا عشان لأنه بلشت الأونست معه أو السيمبتومز عشان يكون عطى الفايبرونوليتكس. And administration of endovascular therapy time from the onset of symptoms. إذا مثل ما شفتوا this is the management time. تمشي مريض السي تي بلان. برجع بقول لكم لحديت أهم نقطة عندي بشد لي قصة الانتربريتيشن. لحديت معي 45 دقيقة تمشي نطلع الريزلتس، لأنه if I will delay the interpretation I will delay the treatment. كله معلق بالانتربريتيشن، ما في يتحرك مواريد ستروك بلا ما اعمل السي تي برين. I cannot manage a patient unless we did a CT brain for the patient. ومعي مثل ما حكينا انه نحن من وقت بتبلش الساينس لحديت الادمنستريشن او لحديت المريض معي 3 ساعات مشان يكون خلص بالبيت، سواء كان بالاي سي يو او بالنورال يونتس. إذا بنطلع على هيدي الشيء المعلومات اللي قلت لكم عنها اللي هي نفسها it needs to be done by or we line of treatment by the American Heart Association. نفس الخبرية اللي هم الأمريكان Heart Association كانوا بيعتمدوها على المانجمنت of a stroke patient مثل ما شفتها already بسطت لكم إياها بس أرجع لكم إياها على السريع اللي هي critical EMS assessment and action, support ABC, perfusion, establish time of symptoms, general assessment, neurological assessment. وشفتوا شو هون السي تي برين اللي تاع hemorrhagic or non hemorrhagic وبيختلف already we mentioned. ما شفنا نرجع نعيدها مرة ثانية already we mentioned. والتايم اللي قلت لكم عنه هذا هو نفس الشيء. 10 minutes, 25 minutes وال 45 minutes. وعندنا 60 minutes و 3 hours. هودي كلياتهم فإذا هذا اللي إنه لازم أمشي عليه من اللاين أوف تريتمنت. بحط قدامكم تمشان. If you would like to take a picture, I will give you just few seconds just to see it and let me know if you have any special question. أعطيكم ثواني عشان تشوفوا هيدي هي بتلخص كل العلاج تبع ال suspected stroke algorithm ونحن على أساسها يعني مثل ما قلت لكم يعني بنعطي treatment للمرض. Have a quick look if you'd like to take a shot of or picture of this. It will be very helpful for you. Okay, awesome. فإذا مثل ما تكلمنا التريتمنت هو يعني إذا كان بيختلف ما فينا نعطي نفس التريتمنت للإسكيميك والهيموراجيك. It's two different line of treatment. Surgical, we have a surgical. Sometimes you might go for surgical treatment, sometimes medical treatment with fibrinolytics or TPA and window 3 to 4 hours. يعني طيب نحن إذا بدي قلت لكم نحن بدي أعطي أنا TPA نحن or fibrinolytics agent نحن شو هي like any medication always there is contraindication. ما في اعطي اي ميديكيشن لاي مريض باي وقت، دائما بده يكون في يعني في اسباب بتمنعني انه اعطي انا الميديكيشن. like what in case stroke اذا المريض عنده one of the following signs and symptoms, it's forbidden to give the treatment for him. Like what? If that patient, for example, what are the type A? هيدي by the way type A exclusion criteria بنبلش ناخذها من الطوارئ، سوري من الامبيولنس. نحن بيكون عندنا ستروك تشيك ليست بنسميها او الفايبروميك تشيك ليست، لانه توصل بدل ما نضيع وقتنا هونيك تنعمل نحن كل هيدي الاشياء، نحن فينا نبلش فيها اوريدي من الامبيولنس. هن ببلشوا تيك انيشيتيفز ببلشوا يعملوا اسسمنت وبنعملوا ستروك تشيك ليست بنسميها او الفايبروميك تشيك ليست. يعني اذا بين عندنا اللي حسميه فيهم الحين اي وحده من هذه النقط بوزيتيف I cannot give fibromyalgics. طيب فاذا what are like what if patient عنده head trauma or prior stroke in the previous 3 months، اذا المريض كان عنده تروما او صار في عنده ستروك خلال ال3 أشهر الماضيه ما في يعطي انا fibromyalgics. If you have symptoms that suggest subarachnoidal hemorrhage لأنه المريض عنده hemorrhage يعطي fibromyalgics يعني it's a big problem. The arterial puncture or non-compressible site in previous or over the last 7 days. If he has a high blood pressure, is a systolic more than 185 with a diastolic more than 110. Evidence of active bleeding on examination is المريض عنده bleeding, I cannot give the fibromyalgics. And if you have a platelets count and heparin received within 48 hours, and the blood glucose and CT, if you have a CT brain as a عملنا CT brain للمريض and it will demonstrate a multi-lobar infarction or hypodensity or the cerebral hemorrhage. فإذا هيدي كمان one of the treatment يعني هي الاندوفاسكولار تكنيك اللي يكون عندنا مثل ما شايفين هنا. It's we have up to 6 hours to do it. We have intra-arterial مش intra-arterial type A injection مثل ما شفتوا هنا. And it mechanical clot disruption يعني بدل ما يكون شفتوا we will do it a clot disruption mechanically and stent retrievals. هذه الصورة هون واضحة how we could do it. And we have window up to 6 hours المعنى لحديت 6 ساعات I could do this intervention. إذا بنشوف نحن المرضى اللي أخذوا لكم شو أهمية التايمينج شو أهميتها، كنا نعمل السيتي برين وبلش بالعلاج، ما في يتأخر عن العلاج. أنتم بتشوفوا إنه شو هو أهمية شو هي كانت الأوتكم تبع مرضى اللي أخذوا التيب قديش كانت عالية. وهيدي بتشوفوا هون المرضى اللي أخذوا التيب كومبير مرضى أخذوا بليسيبو وما أخذوا العلاج. بتشوفوا مثلا المرضى اللي أخذوا التيب قديش كان نسبة السرفايفل ريت وقديش كان نسبة الكومبليكيشن اللي كان عندهم فيري مينيمال كومبليكيشن أو حتى بدون كومبليكيشن مثل ما بتشوفوا هنا اللي هي شفتوا قديش المرضى البليسيبو اللي هي 52%، 43%، 45%، 34%. اللي كان عندهم benefit من أو good global outcome or benefit from the TPA. Potential adverse effect مثل ممكن intracranial hemorrhage، angioedema and transient as. وهون بنشوف number of patient who benefit and are hard. شوفوا عندي مرضى، عندي عدد من المرضى اللي هن أخذوا التي بي اي، ورح نشوف شو النسبة تعرفوا شو الفرق. بتشوفوا هون مثلا عندي 27% من المرضى they get benefit مقابل 1.3 only who get harm. نتيجة هذا مش دائما يعني it doesn't mean from the medication، بس شوفوا انتم نسبة البنفيت. 22.2 patients get benefit from TB لانه مش لانه الميديكيشن بمعنى الميديكيشن، انا وضحت صوره انه لانه اخذوا الميديكيشن وعملوا الاسسمنت وعملوا لهم السيتي برين واخذوا الميديكيشن اون تايم. هذه هي الشغله. وهون بتشوفوا كمان 181 2070. وهون لسوء الحظ كمان نحن بدناش دائما everything in our control. يعني مثل ما كل ما عملنا proper management time management we have a good outcome. كل ما كان عندنا ما عندنا مانجمنت المريض بتبلش من الاسسمنت مانجمنت. شو في يعني فيها مانجمنت يعني فيها الاسسمنت and the time management. الاسسمنت هول كلياتهم بتبلش الاسسمنت من الاول. انا كل ما اتاخر اعمل اسسمنت كل ما اتاخر كل الامبيولنس كل ما يعني هذا الموضوع يتاخر عندي عند المريض. وكنا عن نقص الفايبرولكس كمان اتكلمنا. فاذا just to summarize it انه we need to start begin the stroke pathway اللي تكلمنا عنه من الاسسمنت للترانسفير للمانجمنت والانترفنشن. وهذه بنسميها الباثوي، يعني الطريق اللي بيشتكي المريض. في عندنا السبورت الاي بي سي والبلاد بريشر، المونيتور تمبريتشر اند بيرفورم ديسفيجيا سكرين لانه المريض رح يعاني من one of the complication and monitor the complication monitor the complication لانه مثل ما قلت لكم شفت الكومبليكيشن اذا شيء عند المرضى ممكن if you do not manage it well ممكن المريض يصير في عنده كثير من complication. وترانسفير تو اي سي يو فور further investigation and to continue the line of treatment. والمريض بعد الاي سي يوز we will decide he will go for a rehabilitation process او he will go home بناء على درجه الاصابه والكومبليكيشن اللي صارت عنده. ودائما بيصير بعدين مثل ما حكينا مثل ما قصه انا بشبه كثير مرضى الستروك بمرضى السكر، لانه مرضى السكر ما في علاج وقت بيصير السكر، بس بيصير في عندنا الهدف منها تحسين جوده الحياه. مرضى الستروك ممكن ما يكون فيكم دائما مش مثل السكر لا مزمن، ممكن يصح المريض بس الى حد ما. كمان الشغل مع المرضى بالاخص بيكون في عندهم complication is to improve the quality of life مشان نحسن جودة الحياة عند المريض من خلال الريهابيليتيشن ومن خلال الأشياء الثانية اللي ممكن تصير. This is all for this session. إن شاء الله تكونوا استمتعتوا بالسيشن. And if you have any question please let me know before taking the morning break. إذا هيدي بنكون خلصنا السيشن. إذا في أي سؤال بتحب تسألوني إياه let me know now before giving you the morning break till 10:30. إذا you will have الله يخليكم جميعا. فإذا if there is no question بعد اوكي. فإذا نرجع من البريك إن شاء الله على 10:30 تاخذوا half an hour بريك. تاخذوا البريك drink your coffee، تاخذوا كوفي تستريحوا شوي، وعلى 10:30 إن شاء الله يعني نرجع على الوحدة من جديد. معنا نص ساعة بريك take your morning coffee وعلى 10:30 نرجع إن شاء الله.
Excellent, guys. Thank you very much. So I hope you had a nice breakfast and you come back fresh so we can continue our sessions. But before we go that, just let me have a small introduction. Our next topic is this topic will be talking about, how to assess, manage trauma patients in emergency department and what protocols do you have and how to approach patients with trauma and emergency. Just a couple of things. Ask you, do you see a lot of trauma in your hospital emergency? Can I have some feedback from you guys? No trauma, yes, there are some cases of trauma. Okay, for the hospitals or for the attendees who answer yes, they have trauma cases in the hospital. Do you guys have certain protocols in your hospital to deal with the trauma? Okay, I've seen Fatima saying that she has in everyday many trauma cases in the hospital. Some of the answers, they said they are only medical units. They don't see trauma. Are you saying there's no trauma in the hospital? I mean, regardless, guys, if you are in a hospital that is a level 1 trauma or a level 2 trauma center, we should have some initiative protocols to deal, because as long as you open as a hospital, even if you are medical, everything is restricted. MVA or trauma happen at the door of the hospital, and they might bring the patient to the nearest hospital. Sometimes, families, they're bringing the patients, not all the time Red Crescent. I know Red Crescent, they will bring the patient to the closest, trauma hospital or level 1 trauma hospital. But sometimes this is what we are suffering, families, they're bringing the patients. They drive them to the hospital. So even if you are a medical emergency, it's preferable, if you have a trauma policy, trauma protocol to deal in case of a trauma. Actually, it is beneficial for the centers that they don't see frequent trauma. So for centers that seeing trauma every day, I guess, it's going to be very easier to deal with the trauma or patient. However, if you are a hospital that they don't deal with a trauma, it is recommended that you have a protocol, because we don't see trauma every now and then. So it's as long as rarely happening in your hospital, you should have protocol that mandate the members, the individual, how to respond to a patient with a trauma. So this is a take-home message today. If you're a medical emergency, please, try to find, a protocol to deal in case of trauma happening, because still, yes, you are a medical, but the percentage that you might have a trauma at the door of your hospital, at the door of your emergency, and you need to know how to deal with this trauma. So let's all agree that we should all have a trauma protocol. And in a level 1 trauma hospital or level 2 hospital, they should have also a trauma code team. So in case of a code having or trauma having, you have individualized people or team that they should respond in case of trauma. And this is involving your department of surgery, neurosurgery, orthopedic, and also other, healthcare employees, example, radiology, to make sure that the CT or the MRI, if needed, it will be available. Radiologists, to read the reports, and interventional radiologists as well. Nursing supervisors also to be available in case if you need OR, urgent OR, if you need urgent, cath lab or cardiac surgery. So let's go and we'll take this one as a scenario and we'll walk through this scenario, how we can. So this is a 44-year-old male driver, crashed head into a wall. The patient was found unresponsive at the scene. He arrived at the hospital via basic life support with cervical column in place and strapped to a backboard. Technicians are assisting ventilations with a bag mask. How can we best assist this patient quickly? How we make sure that, we provide, the advanced trauma life support for excellent, Kinder saying ABCs, rapid head to toe. Yes, all of this. Start with the ABCs, partner saying. Excellent feedback, guys. But before we start, about our primary survey, secondary survey for this patient, I just want to put the slide, which is the trimodal death distribution. And can you see after the trauma happens, or for a patient, whether it's a motor vehicle collision or a motor vehicle accident or a fall or any kind of trauma, that whether it's head trauma, blunt trauma, chest trauma, abdomen trauma, okay? I want you to see, the survival rate for the patient and the death that could happen for the patient after the trauma. So most of the, the consequences or complication or the death, okay, could happen in the first 30 minutes, okay? And this is considered a very crucial time for the healthcare provider where they can prevent any other injuries for the patient. So trauma happened, injury happened to the patients. The question is here is how to prevent, secondary injury, how to prevent death. And this is, the golden, time, the golden hour, the first 1 hour that, as you see, 50% of the people, they die in the first 1 hour after the trauma. And you see it when we continue, so the 30%, in the subsequent hours might take, days and weeks. There's a 20% of people, later on, they die. So Jessica, I'm not sure what you mean English translation. Can you elaborate more, please, Jessica? So let's talk about the golden hour. The golden hour of care after injury is characterized by the need for rapid assessment and resuscitation, which are fundamental principles of advanced trauma life support. As we said, 50% of death happen in the first 1 hour. If we manage to do advanced, life support within this 1 hour, resuscitate and intervene with the patient, we probably, decreasing the percentage of death for the patient. The first 1 hour after injury will largely determine critically injured person's chance of survival. So that's very important, how much you are prepared, how much you are aware of the advanced life support, standard of care and protocols. This will benefit the patient for the survival rate. So if you're really ready and you have the protocols and you follow the protocols for the advanced trauma life support, you will manage in 1 hour to decrease, okay, the deaths that could happen for the patient or the subsequent injuries that happen after the primary injuries. ATLS guidelines, said preparation. So if you receive a phone call that a trauma is coming or MVA is coming, okay, and triage is happening at the scene or triage happening while when the patient arrived, then the patient will arrive to the hospital. You start with your primary survey, A, B, C, D, E, and your resuscitation later on. Then you try to do the adjunct to primary survey and resuscitation. Then your secondary survey comes after. Then the adjunct of the secondary survey. Continued post-resuscitation monitoring and re-evaluation, and finally the definitive care. The importance of the first 1 hour is not to mix your secondary and your primary together. So you don't have time, you don't have the luxury to give in 1 hour your secondary survey or other adjunct that comes with the secondary. So you're going to be mainly focusing in your resuscitation skills and your A, B, C, D, E. Now, if trauma happened outside the hospital, okay, and you will get notified by as a receiving hospital, and you should prepare and understand what's happening exactly, how many casualties in this, what is the mechanism of injuries for the patients, okay, and airway maintenance, control of external breathing, shock, immobilization of the patient. This is all having as a pre-hospital. The patient will arrive to you, okay, with, might be, intubated, might be, high flow oxygen, might be, would also present with C collar. Once the patient, start to come inside, we start with the in-hospital phase. Resuscitation area. Make sure that your code room is, ready, has all the equipment and supply to take care of somebody who has, a massive trauma, somebody who has, a major trauma, blunt trauma, open trauma, and get your equipment monitored and to be checked, your warm fluid. If you don't have, a warmer in your department, make sure that you get one. Otherwise, you make sure that the fluids are warm when we give it to somebody who is in a trauma or in a shock. Trauma team, get your team ready. ER specialist, neurosurgery, depends if it's a neurosurgery trauma or involving the head, or it's a, thoracic need to be involved, or general surgery, or orthopedic. Depends on the type of the trauma where you're going to activate the core team. And protective communicable disease, always think about, your safety and your team safety. Okay, Haya asking why we need a warmer fluids. With there's a high risk, especially with the exposed patient is losing fluid, patient has bleeding, patient will be exposed for quite some time, whether in outside or inside the hospital facility. Those patients, there will be hypothermia. Hypothermia is one of the also factors that may complicate the situation for the patient and making the consequences, bad. So we want to prevent hypothermia for the patient. That's why we need a warmer fluid. Triage. Now it depends how much casualties you are receiving. Are you receiving multiple casualties or are you receiving mass casualties? And sorting the patient according to the ABCDs available resources. So if you have 10 bed in your emergency, 15 bed, and there's a bus turned over, or airplane crashed, or a building explosion, any kind of that could involve a mass casualties, okay, and it is beyond your resources, beyond your equipment, beyond your supplies, capabilities, these are mass casualties. And when it comes to the triage, when you do triage for mass casualties, you will not be able to serve all of them. So you're going to make sure that you get take care of patients, they might survive. Those patients who have the ability to survive, yes, you invest time in them and try to restate them and do the ABCDs for them. Patients who are needing more resources and you think their outcome or prognosis is going to be very bad, those patients, they will not be taken care of. And this is the principle of the mass casualties of triage. You do the best for the, the most people who will survive. When it comes to the multiple, you have 1, 2, 3 casualties. Now you're going to invest heavily in their, assessment, intervention, all of them, because you have a limited number of casualties, and still you can do everything, even for the one who might have a bad or poor prognosis. As we said, multiple casualties, number of patients, do not exceed your resources. Treat first patient with life-threatening and multiple system injuries. Okay. When it comes to mass casualties, now severity of injury, number of patients are exceeding your resources, so treat the patient with the highest chance of survival. So if you think this patient, he will maybe die in 1 day, or he might die in a few hours, okay, and you don't waste your time and your resources to survive or to help this patient, because at the end, whatever you're giving to this patient, he will be, there will be a bad outcomes coming out of this patient. So you don't waste your limited resources in patients that they don't have a chance. Is it clear, guys? Is it clear for you at this point? Excellent, yes. Primary survey and resuscitation, airway maintenance and C-spine control. Then breathing and ventilation. C stands for circulation and breathing control. D for disability and neurological status. E, this is what we called about warm fluid, is your exposure and your environment. So adult and pediatric priorities, okay, when it comes to the same ABCDs, ABCDE does not differ between adult and pediatric. You're still doing the same thing when C-spine, ventilation, and breathing control. Back to our gentleman who had crashed his head in a little wall. What do we do with the airway? So with the airway and cervical spine control, or oral foreign bodies, facial, mandibular, tracheal, laryngeal fracture may result in airway obstruction. So talk to the patient, check the airway patency, secretion, blood stridor, C-spine protection for those patients. The pitfalls, الأشياء اللي ممكن تكون that could inhibit أو الأخطاء أو pitfalls معناها بالعربي المنزلقات، الأشياء اللي ممكن إنك تبعدك عن الشيء الصحيح. Might inhibit successful trauma resuscitation. Intubation is difficult airway, patient with difficult airway. Obesity, patient need a surgical airway, cannot perform smoothly. Laryngeal fracture or incomplete upper airway transection. Those patients, are difficult to treat, difficult to deal with, and they need, special, maybe they need ENT, they need other services, anesthetists for intubation and managing their airways. Airway maintenance and cervical spine control, basic airway management. We use the jaw thrust, okay, for the patient with a trauma as a maneuver, remove the foreign material from the mouth, oropharyngeal or nasopharyngeal airway. Definitive airway, orotracheal intubation, nasotracheal intubation, surgical airway. Trichothyroidotomy or tracheostomy for this patient if they need definitive airway. Now we're talking about the nasotracheal intubation or nasopharyngeal airway. These are the ones that should be, avoided if you have somebody with basal skull fractures. This is a needle cricothyroidotomy. You should have an airway card in your emergency department that have a needle cricothyroidotomy in case if you have somebody with, laryngeal edema, somebody with maxillofacial trauma, somebody is difficult to be intubated. This is an easy access where to open the airway for patients who have obstructed or, unclear airway for intubation. You're going to check the patient respiration, chest movement. Is it bilateral? Is it equal? Respiratory rate, tracheal position, is it deviated, not deviated? Breath sounds, hyperresonance sounds. Is the patient having? We'll go back to this. Okay. The airway maintenance, the definitive airway. What are the type of definitive airway? The basic airway management. Okay. These are the ones. And if patient have chest trauma or have blunt trauma, that might cause pneumothorax for the patient. So if there's a tracheal deviation, there's hyperresonant sounds. If you see there's no air entry, you're not feeling not hearing the breath sound on one side. So you need to prepare for patient, having chest drain ready, and watch for subcutaneous emphysema, inspection of neck veins and wound, all of this, with the breathing and ventilation. Injury that may acutely impair ventilation should be identified in the primary survey. So in the primary survey, when you do the primary survey and you found there's, injuries to the impairing the ventilation, you need to intervene. You cannot, assess and, continue with the A, B, C, or you move to C. No, if you find a problem with B, fix B. Fix B, and let's say tension pneumothorax or flail chest with pulmonary contusion. This patient needs urgent, needle decompression if it's, and start also chest tube. Massive hemothorax, open pneumothorax, airway patency, adequate breathing, and ventilation. So you're going to make sure that the patient is adequately breathing and ventilating. Tension pneumothorax, immediate decompression, as Kendra said, needle decompression, rapidly inserting a large bore needle, like gauge 20, into the second intercostal space, midclavicular line that affected to the side. And the definitive here is to put a chest tube for the patient, but the immediate relief using the needle decompression. Circulation and bleeding control, blood pressure, pulse rate, level of consciousness, skin color, cab refill should be assessed for the patient, and look for external bleeding side. Internal bleeding side, you're going to look for blood on the floor and for more. The response for elderly children, athletes, and others with a chronic medical condition of hypovolemia is different from normal people. And this has to be, in your mind always with the patient. As we said, we have special groups like elderly patient, children, when it comes to the hypovolemic shock. If there is blood in the floor, you're going to look for external side for the blood, control the bleeding, and you look for four more. Four more is your head, your chest, your abdomen, and your pelvis. These are the cavities where my patient might have bleeding internally. Also intervention, you need to apply direct pressure to the external bleeding. Too large IV you do all the labs for the patient, cross match the patient, warmer fluid, blood transfusion. If you have a warmer, also use the warmer. There's a warmer can be used even if you don't have a fluid that are warm. So you're giving warmer blood, you're giving warmer fluid, and if there's a suspicion of pelvic fracture, use the pelvic stabilizer, traction, surgery. No tourniquet except if there's an amputation. So if the patient already come with injuries that resulted in amputation of one of the limbs, so this is the time you're going to use the tourniquet. But no tourniquet to be used for internal bleeding to stop the bleeding. Pericardiocentesis, if your patient having, pericardial effusion. Hemorrhages control is the primary goal. So that's the primary goal when it comes to the circulation and bleeding. Fluids for trauma patients. In patients with compensated shock after blunt trauma, a fluid bolus form, normal sign, or regular lactate should be rapidly given over 10 to 15 minutes. Excessive infusion of crystalloid has been associated with worse outcome in patients with severe hemorrhage. Many hospitals have blood product immediately. So if you think the patient having a massive, bleeding, okay, yes, you can start with the fluid, but you need to give all negative blood for the patient and start, request if you don't have a massive transfusion protocol, please activate a massive transfusion protocol in your hospital where you can get, 6 or 12 minutes of packed RBCs, or you can give it to the patient immediate transfusion rather than fluid resuscitation, because fluid resuscitation has also complication if it will continue with the fluid. Ringer lactate and blood must be infused through a separate, IV tubing because risk of clotting. So if you are giving blood and you're giving also fluid, these RBCs might be clumped if they are, with the fluid. The only fluid that does not cause a clumping of the RBCs is the normal saline. So separate them in different lines. And this is might causing hemolytic anemia for the patients. So make sure that they are not running concurrently in the same line, because otherwise, instead of helping the patient, you make the scenario worse, and the patient might have hemolytic anemia. Pericardiocentesis of the patient, having pericardial effusion, you have a 16 to 18 gauge needle that goes in a 45 degree in the above the xiphoid, process okay, the pericardial sac, and try to aspirate the fluid or the blood that in the pericardial sac. Now this can be confirmed by a physical assessment, or can be confirmed by doing a quick ultrasound or echo for the patient. The D is your disability, your guys, Akram saying the voice, the sound, is it clear? Okay, thank you very much. So for neurological status, your GCS, pupil size, light reaction, anticipate intubation if GCS is less than 8. Prevent secondary brain injury, which is very important. As we said, our aim to prevent, complication, to prevent, secondary injury. Manage hypotension with the fluid and blood. Remember, once your map falls down, okay, that means cerebral perfusion pressure also will decrease. So in order to keep a good perfusion to the cerebrum, you need to have a good map. So you need to all the time to make sure your cerebral perfusion pressure is in a normal or subnormal. So at least, your brain will not get affected and will not have ischemia or infarction related to low cerebral perfusion pressure. As we said, there's any neurological deficit, neurosurgery has to be part of the trauma code, and they should be available in case if they need an urgent, EVD, urgent craniotomy that might need it in the ER. Don't get the, tricked by, a lucid interval. When we talk about lucid interval, we talk about the people who came, walk, and talk, and die. Frequent neurological re-evaluation can minimize this problem. Some patients, they might arrive to the ER, okay, they are talking and they think, their GCS is, 15/15, they're shaky, they are scared, those patients actually, they talk and die, they call them, lucid intervals. So make sure that, you assess your patient and make sure that especially for the EDH with the epidural hematoma, those patients, they walk and die. They came as shaky, they might be walking, they're asking for just, regular checkup, 15 minutes later, you find them, unconscious. Exposure environment enters the patient to see all the wounds, all the, again, please check your connection, check your mic, because everybody's saying the sound is clear. Examine the back, examine the extremities, examine the head of your patient, all entry and exit, wound, and prevent hypothermia, as we said. Warming light, warming blanket, warm resuscitation fluid, warm, even if the patient, talk to the ventilator, make sure that they're using warm, air. Patient rights, closed area, privacy, confidentiality with this. Early control with hemorrhoids will minimize the hypothermia. As we said, warm fluid, warm blood, and control the heat. Adjunct to the primary survey is your vital signs. That's the primary ECG, O2 saturation, urinary catheter. If there's urinary injury, blood at the meatus, pelvic fractures, scrotal blood, cranial bruising, avoid, using the urinary catheter. Gastric catheter, okay, urine output, trauma film, chest X-ray, and pelvis. These are the X-ray that can be done in the primary survey. Nasogastric tube, as you can see, is inserted for somebody who having, as all of you see, Raccoon eyes, basal skull fracture. Avoid using, nasogastric because you might intubate, the brain, or with this catheter because the skull is open, might migrate to the brain. Secondary, you're going to do your history, physical exam, head to toe, tubes, fingers, in every orifice. So everything is open. You're going to see if there's any tubes which can be done. Complete neurological exam, head to toe, special diagnostic test. That's the time you're going to do more X-rays, more images, and re-evaluation for your patients. Secondary survey also contain your ample allergies, medication, and past medical history, and the last meal that the patient had. And any event, you ask about the event, what happened exactly to the patient, how did the patient feel, how did the MVA happen, how many people injured, what type of injury to the car, what was the speed, was the patient restrained, not restrained, was he front seat passenger, was he, backside passenger. All of these, events and should be taken in the secondary survey. It should not be, get, the primary physician, Adjunct to the secondary survey is your CT scan, contrast, X-ray studies, extremities, ultrasound. These are your secondary surveys. Now, remember about, especially for pediatric, about the urine output, okay? It's very important that you keep monitoring, the patient parameter. Example, the urine when it comes from 0 to 2, the normal is 1.22 ml per kg. You go up to 1 ml per kg for 3 to 5 years. And when you come to 6 to 12 years, you have 0.5 to 1 ml. More than 12 years, like adults, the normal urine output is 0.5 to 1 ml per kg. As we said, we are not inserting routinely a full catheter unless, there's no like injury, there's no pelvic fracture, there's no blood, okay? So after you get examined and there's no injury, we will insert, the full catheter. Definitive care, okay, is OR. Patient might go to the OR. Patient might go to the ICU and or referral. I'm trying to open this primary survey ATLS video for you guys just to watch. Can you see it? Okay, wait a minute. Let me try to share it with you. Can you see it now? Can you hear the voice from that sound? Check why there's no sound on this one. Try to make it. Guys, can you hear the sound? I'm not sure what's the problem. Some of you, they said the sound is clear. But you can see what, how they do the ABCD, the primary survey, secondary survey, and the adjunct for the patient. I'll keep you guys with the video. Assalamu alaikum. Hello, guys. We will share the presentation with the coordinator, and she might share the link with you. I'm not sure what's the problem with the. Can you hear me now? Okay. I'm not sure what's the problem with the sound, but we'll share the link and they can share it. Thank you very much. We'll give you 2 minutes before we start the next session.
السلام عليكم. Can you hear me? واضحة الصورة سلايد وواضح الصوت؟ اوكي والصورة واضحة؟ اوكي. Okay, our next session will be talking about the sepsis. مثل ما اتكلمنا sepsis, which is it's a life-threatening condition for the patient, and the patient with sepsis is a top emergency. Okay, this is a top emergency. Increase the slide. Okay, good. طيب, in this session we will be talking, as we said, about the sepsis. هنتكلم الحين عن السبسس وشو what are the definition of sepsis, what are the causes of sepsis, the risk factors, the signs and symptoms, the clinical manifestation, the SOFA score, diagnostic test, the treatment, the nursing consideration, summary, and the reference. So, as this is a very important topic. And the major of our, we have a good number of our ICU's patients, they have already a sepsis. That's complication. And you will see now what they mean by a sepsis. First of all, let me give you a few definitions. in order to understand the sepsis very well. The first one will be the SIRS, or the systemic. What do you mean by SIRS? This is a systemic inflammatory response to a body for an infection. For example, you have, it's a life-threatening medical emergency. The family or our body or our will react due to a severe infection, and this is a life-threatening condition. Okay, it's a life-threatening condition for the patient. As our body will react due to the infection, and it's a life-threatening medical emergency. The sepsis is a clinical syndrome defined as a life-threatening organ dysfunction caused for the infection. For example, what will happen? Our body will react to the infection. This is the source. Due to this severe infection, or due to this infection, we might end with a sepsis, which is a life-threatening condition, and it might lead to an organ dysfunction. Clear? فإذا هذه الباثوي اللي بتمشي فيها يكون في عندنا infection، بيكون في body reaction. The body reaction it might have to lead sepsis، اللي هو ببلش في عندنا بنسميه organ dysfunction. Severe sepsis is a sepsis with an acute organ dysfunction. Septic shock هم بلشنا بالحالة الحرجة عند المريض is a subset of sepsis in which circulatory, cellular, and metabolic abnormalities are associated with a greatest risk of mortality than with sepsis alone. هم نشوف إنه بيصير في عنا organ failure، بيصير في عنا circulatory, metabolic, and circulatory metabolic يعني hemodynamic instability like hypotension symptoms, and it will require the the vasopressor support since the map is failure. For example, just for you to know that we have to start with the source, with the systematic inflammatory response, followed by a sepsis. Then it might lead to severe sepsis, and we will be with the organ failure and death. This is all as definition. And this is for example, this is the picture how it will start. And it will give you, we have an infection. It might be any types of infection, severe epilepsy or whatever. Then the patient, he will have the SIRS, which is by the following signs and symptoms, which is the high temperature WBC, high temperature more than 38 temperature, and we have the high WBC. Then we will go for the sepsis SIRS plus infection. Then we have severe sepsis, which is a sepsis plus, here you will have the end organ damage and septic shock CVS as well as potential as مثل ما تفضلت وحكيت عن الأخت غادة اللي هي بنسيب السيفير sepsis. فإذا this is the chain, or this is how you start with an infection and you will end with severe septic shock. And this is the picture. If you could like to take it, it's very beneficial. In هذه السلايد بتفسركم أو بتعطيكم فكرة عن كل السيشن. How from where it will start and how it will end. وضحت؟ عظيم, excellent. What are the causes of sepsis؟ ليش المريض بتسألوني طيب إذا المريض وصل لمرحلة الأورجان فيلر وهايبوتنشن نتيجة الانفكشن، شو هي الانفكشن and what are the causes of sepsis? Most sepsis is caused by a bacterial infection, as in the first and cause or the leading cause is the bacterial infection. but it might be a complication of other infection, including the viral infection such as COVID or influenza. يعني وقت بيكون it's fast than the cause, main cause it's the bacterial, but it might be caused to other, not only it might be caused to a viral infection, especially COVID-19 or influenza. As due to severe infection, ممكن المريض يصير في عنده this is the sepsis. الأكثر شيء the pathogenic responsible for the sepsis is Staphylococcus or Staph aureus or E. coli and some Streptococcus. فإذا Staphylococcus, E. coli و Streptococcus هن أكثر شيء bacteria responsible for the sepsis. By the way, سواء bacteria or viral, they might have a similar presentation and a similar clinical course to some form of sepsis. مين من المرضى or who are at risk of developing sepsis؟ إذا مين من الأشخاص المعرضين أكثر شيء اللي يكون في عندهم sepsis؟ إذا people at risk or who are at risk to have a risk of sepsis. أول شغلة بيكون دائما تعرفوا اللي بيكون عندهم immunodeficiency problem, especially extreme age or after 60 years old and above, mainly the pediatric and Nasal. فإذا الأمراض أو الأشخاص اللي بيكون عندهم مشكلة بجهاز المناعة اللي هن إجمالا معروف الأشخاص اللي بيكونوا كبار بالعمر والأشخاص اللي بيكونوا البيدياتريك اللي بيكون بعد جهاز المناعة عندهم مش مكتمل، والأمراض الأشخاص اللي بيكون عندهم أمراض العلاقة بجهاز المناعة اللي هي السكري وإلى آخره. هؤلاء الأشخاص كثير مع مرضين يكونوا مع الموضوع. اللي بيكون عندهم كمان chronic medical condition مثل diabetes واللانج ديزيز and cancer، اللي بيكون عندهم مثل ما حكينا أمراض جهاز المناعة weak or immune system and the sepsis. هؤلاء من الأشخاص who are at high risk of developing sepsis due to severe infection. What are the signs and symptoms of sepsis? This is, if you see this picture, رح تشوفي المرضى كيف how you notice if your patient already start developing a sepsis. يعني كيف بتلاحظوا إذا المريض عندكم بلش يكون في عنده sepsis. First of all, we have what are the signs and symptoms? In a patient, he might have one or more of the following. ممكن يكون في عنده علامة أو علامتين أو كل هول العلامات اللي بيدلوا إنه المريض. But if you notice that your patient has one or two or more of the following signs and symptoms, you need to call I don't know if you have a sepsis team. In most of the leading hospital now, we have a sepsis team. I don't know if you have, but so far, just for your information, if you notice any one of these following signs and symptoms, you need to notify, at least we call the RRT or rapid response team, or activate the sepsis team. What are the signs? أول شيء the high heart rate and low blood pressure, يعني tachycardia and hypotension. I think this is one of the major signs and symptoms, which is like tachycardia and hypotension. Fever, shivering, or feeling very cold. طبعا, since we have infection, سواء كانت viral or bacterial, رح يكون في عندنا fever. بالأخص وقت بتكون bacterial we have a high fever grade. يكون في عندنا المريض he will start having a confusion or disorientation. He will have a shortness of breathing, some of the extreme pain or discomfort, and clammy or sweaty skin, which is reflecting vision. فإذا هذه العلامات اللي ممكن مريض الكوفيد يكون عنده إياهم، مثل ما تكلمنا الهاي هارت ريت، بالأخص قصة المريض مثلا المريض بيكون بالآي سي يو يكون كونكتد على المونيتور، كيف بدي أعرف إنه عنده سبسس؟ لاحظ بالأخص قصة التاكيكارديا هايبوتنشن، بيكون المريض بلش عنده هاي تمبريتشر ويصير في عنده نوع من الكونفيوجن وسويت سكين أو كليمي سكين. بس هودي أكثر علامات ممكن نلاحظهم عند المريض وقت يكون عنده sepsis أو septic shock. مثلا this is مثل ما قلت لكم إذا بتلاحظوا شغله جدا مهمه، إذا بتلاحظوا أي علامة من هول العلامات عند المريض لازم you need to call the sepsis team or the RRT or activate the RRT. مثلا what are the following signs and symptoms اللي بتكلمنا عن body temperature more than 10 and can be less than 35, heart rate more or tachycardia more than 90 beats per minute, and the respiratory rate it's كمان بيعمل like tachypnea or polypnea, and he has 20 beats, which is supposed to be 16, now it's 20. And white blood cells, or white blood count, it's more than 1,202 or less than 400. طبعا إذا كان WBC or fever because of the refractive infection. شفنا في إذا كان high temperature with low or regardless مهم تكون وحدة من الموجود طبعا. بس أنا مثل ما إذا اتجاه للسلايد الثاني وضحت إنه نحن بنكون عندنا إذا بتشوفي نحن شو حكينا هون one or more symptoms ماشي بدات على وحدة ممكن تكون high WBC temperature. يعني if you have one or two or more of the following signs and symptoms, maybe 1, 2, 3, 4, 5, 6, this is a high risk of sepsis, and you need to activate the message. It's clear. You need to activate the RRT or to call the septic team. Now how we have what we call the SOFA or the score or the sequential organ failure assessment. يعني مثل ما بتعرفوا نحن تكلمنا انه this is patient he might have and with a organ failure. مشان هيك this is a highly critical condition for the patient. What will happen in the sepsis clinical criteria? It's very clear here. يعني infection due to any type of infection, UTI or CLAPSI or whatever, you know, it will change in the sepsis-related organ failure assessment. يعني نحن كيف نعمل assessment or the SOFA score or the sequential organ failure assessment score. How are we going to give a score in order to see the organ failure and the proper assessment for the patient? We are going to assess the four system or whatever system. أول شيء نبلش بالrespiration. The PaO2 and FaO2 and you will score it accordingly. We have the coagulation profile. We have the liver bilirubin, and we have the cardiovascular, especially DMARD, and GCS or Glasgow Coma scales. And this is how we, if let's say, for example, if I will give you an example of GCS or let's say if he's fully awake means 0. If it's the GCS between 13 and 14, you will give a score of 1. If the GCS between 10 and 12, you will give a score of 2. If the GCS between 6 and 9, you will give scores of 3. And if the GCS is less than 6, أقل من 6, ساعتها بنعطي score it's 4. And here this is the same of respirating. It's the same of coagulation. دائما فإذا نحن حسب الريزلتس على السيستم اللي هي respiration, coagulation, liver, الكارديوفاسكولار ماب، السيستم نيرفس سنتر اللي هي GCS والرينال كرياتينين كمان نحن we will give a proper score which is starting from 0 up to 4. And based on the result, we will see, you know, if you will confirm this is the what we call it the sequential organ failure assessment score or the SOF. Now, how are going to test a patient؟ احنا صار في عندي انا مثل ما قلت لكم علامات الحيويه اللي حكينا عنها وعملنا الاسسمنت والدي اورجان فيلر اسسمنت. احنا الحين بدي اعرف انا if in case I suspect a patient with sepsis, how I'm going to diagnose or what are the diagnostic tests. First of all, we have the laboratory tests including blood culture, CRP, procaryotin, and lactic acid. This is how we could see it. We have the urine culture, the sputum culture, we have the chest X-ray and swab or any open wound. And this is how the initial department as diagnostic test in order to assess the patient if he has a sepsis or septic shock. مثل ما حكينا as a laboratory test which is very important. The blood culture, CRP, وناخذ urine culture, sputum culture, chest X-ray, and swab of any open wounds. مثل ما شفتوا هنا هذه الصورة واضحة فيكم تشوفوها. And especially X-ray تعطيني فكرة. والswabbing very important. The blood culture and mainly the blood culture. Now treatment. The nearest أول شيء the earlier the better. Antibiotics. طيب نحن my question to you. بأي حال أنا في أعطي antibiotics for the patient with sepsis and what kind of antibiotics وشو بخاف بقصة prescription of antibiotics for the patient with sepsis. In which case we give antibiotics وشو اللي بيخوفني بقصة الانتيبيوتكس لما نشيل مرض السبسيس يعني ممكن يكون في عنده رياكشن على شيء معين أو what do you think? Golden hour might be bacterial or viral طبعا. Allergy make sure to check. Excellent. طيب شو أخطر شيء بقصة السبسس إذا والبريسكريبشن أوف أنتيبيوتكس؟ أنا المريض ما بيصاب غير السبسس. Allergies make sure to check. طبعا بدنا نعمل make sure إنه نعطي antibiotics especially if you have severe sepsis. طيب what else؟ في شغلة جدا مهمة لازم نعمل. organ failure. resist. thank you خديجة ممتاز جدا جدا جدا. شيء بنسميها مالتي MDRO or multi drug resistant. اكثر شيء نحن شو بنخاف عند المرضى اللي بيكونوا منومين بالاي سي يوز من فتره طويله بدهم ديفلوبمنت السبسس بنخاف بنسميها MDRO or multi drug or resistant. يعني بيجي المريض يعمل جسمه ريزيستنت على كل انواع المضادات الحيويه. يعني بنكون احنا بنجرب نعطيه هيدا السبيكتروم او هيدا الانتيبيوتكس ونبين انه عنده ريزيستنت. بنجرب نعطيه نوع ثاني كمان من الانتيبيوتكس بين عنده ريزيستنت. نجربنا منه كومبايننج ريزيستنت. هيدا اخطر شيء ممكن يصير في عند مريض الاي سي يو انه يعمل ريزيستنت على المضاد الحيوي. هذا اتس لايف ثريتنينج. المريض ممكن ما يباس اواي. يعني هيدا اخطر شغله ممكن يوصل لها المريض السبسيك اذا المريض عنده مالتي دراج ريزيستنت او بيكون في عنده ريزيستنس على انواع المضادات الحيويه. دائما for everything we need to control the source of infection. It's a medicinal resistant staph aureus, let's say, because of the wound. أنا بدي I need to treat the wound لأنه this is the main cause اللي هو كلف. إذا we need to treat the reason, we need to treat the cause, and always there was all type of patient we need to have the fluid management and maintain blood flow to vital organs. Perfusion, good perfusion, treat the cause, prescribe the proper antibiotics as soon as possible, and avoid the multi-drug resistance because this is a very critical case that the patient he might face it. في حال كان عنده MDRO. هذه شغلة جدا مهمة. تكلمتي هون حدا من الاخوه تكلم عن ال 1 hour bundle او golden hour. This is هيدي اللي عم نسميها الجولدن اور اللي تكلمنا عنها. قلت لكم كل المعلومات رح تكون موجوده عندكم. شفتوا هاي الجولدنج اور اللي بنسميها اول شغله الميديكال ايمرجنسي ريكوجنيشن اوف سيبتيك شوك تكلمنا عنها. فاذا اول شيء الميديكال ايمرجنسي ميجر ذا لاكتيت ليفل لانه بتعطينا قديش نسبه اللاكتيت ليفل. ثاني شيء obtain blood culture before administration of antibiotics. فاذا كمان انا مثل ما قلت لكم بدي اعمل انا blood culture تشوف اي antibiotics انا بدي اعطي. ما في اعطي مضاد حيوي ولا بلا ما يكون المريض بلا ما اكون عارف انا شو نوع البكتيريا. Blood culture, administer the antibiotics if you know what type of antibiotics we need to this one. في عنا we will start مثل ما حكينا انه لانه one of the signs of severe hypotension we need to give a rapid administration of crystalloid. مثل ما كنا نتذكروا انه نحن حكينا انه المريض كثير بيكون عندهم tachycardia and hypotension. We need to treat it or by starting a good antibiotics. ما حكينا عن قصه اللاكتيت وقت بيكون في عندنا اللاكتيت هاي وقت بناخذ البلاد لاكتيت بنشوف وات ذس مين. اذا كان عندنا اللاكتيت هاي اتس بتعطينا انه the severity of the condition انه this is a severe condition بتعلي اللاكتيت. فاذا نحن اهم شيء مثل ما حكينا الجولدن اور 1 hour bundles monitor the patient confirm the case measure lactate level. انا سمحت لكم lactate level بتعطيني الايديا عن ال severity of the infection lactate accumulation. ناخذ سكريننج او الكالتشر بنشوف شو المضاد الحيوي اللي لازم ينعطى. بعدين بنقول ستارت نعطي الكريستالويد and to treat the hypotension. And we will apply vasopressors of hypotension during or after fluid resuscitation. This is very important for the patient to do. Nursing consideration مثل ما حكينا if you have any doubt you need to activate the septic steam or to activate the RRT. We need to the early recognition and the signs and symptoms of this one. Prevent infection by the go or follow the infection control guidelines and educate the family of the patient about the early signs and symptoms in case you have a shock. كيف بيعرفوا انه المريض just to inform the healthcare practitioner. Prevention, always the prevention of infection that as at the end sepsis it came from a source اللي هي infection and we need to prevent the infection in order to prevent the sepsis in order to prevent the organ failure ونفوت المريض بدراج ريزيستنت والى اخره لانه اكثر سبب للمرضى في كثير مرضى بالاي سي يوز they will pass away because of the sepsis. As an overall, just to prevent the infection, and the main way to prevent the infection is to go through the hand washing. To go through the hand washing. دي أكثر source مثل ما بتعرفوا هي قصة الهاند washing عند المريض and the other signs of من خلال infection precautions هي personal protective equipment وإلى آخره. Summary: the sepsis will happen when an infection present in the skin, lungs, air, urinary tract, or somewhere else that trigger a chain reaction through the body. It's a complication of infection, as in sepsis, complication of infection, mostly caused by bacterial infection, and it could be complicated with the viral infection like a COVID and influenza. It's a medical emergency. Without timely treatment, sepsis can rapidly lead to tissue damage, organ failure. Sepsis قد يكون لا damage بالtissue, لا organ failure, and to death. The early recognition recognition and treatment is the key point for chance of survival and better patient outcome. فإذا كل ما عملنا recognition earlier، كل ما بلشنا بالتريتمنت، كل ما بلشنا بالتريتمنت أسرع، كل ما بلشنا بالتريتمنت أسرع، كل ما السرفايفل ريت عند البيشنت يعلى، وكل ما يكون في عندنا better outcome، كل ما يكون outcome المريض لسه أحسن وأحسن. فإذا هيدي as a summary of the session، هيدي الأشياء اللي إحنا المفروض ننتبه لها لقصة الانفكشن prevention of the infection مشان نمنع السبسس، لأنه كله بيجر على بعضه. السبسس رح توديك على organ failure، رح توديك على tissue damage، it might lead to death. بالمقابل كمان نحن بما إنه for a reason المريض صار عنده سبسس، نحن we need to treat the patient بنشان، لأنه وقت ما نبلش early treatment مثل ما حكينا قصة الكالتشر والى آخره، بنعلي السرفايفل ريت، بيكون في عندنا better outcome لعند المريض. Always we need to support the sepsis, because by supporting the sepsis or by avoiding the sepsis, مش supporting sepsis يعني I mean just supporting this pathway because it will save the life of the patient. Clear? Do you have any question? أي سؤال before moving to the lunch break and the prayer time? Do you have any questions? If you have any question, I will. اوكي ثانك يو، شكرا على الحضور، وان شاء الله بنلاقيكم على الساعه 1، تاخذوا برايك الحين الساعه 1 وبنلتقيكم على الساعه 1 ان شاء الله. Good afternoon. Can you hear me? Hello, السلام عليكم. عظيم. اوكي. طيب. حنبتدي الحين لفترة ما بعد الظهر more session about the critical care والemergency، والحين حنطلع على موضوع شوي يعني it's very important اللي هو reduce length of stay of ICU. طيب. Do you think why it's very important to have to reduce the length of stay for an ICU patient? المريض is admitted to ICU for a reason. For sure, for a severe reason, it could be medical or surgical. Our role just to support this patient and to avoid any harm. Can you see the slides? No, okay. طيب لحظة بس. لحظة إذا let me. بس لحظات لو سمحتم بشوف ليش. اوكي. الحين السلايد واضح؟ اوكي عظيم، شكرا لكم، ثانك يو. طيب فاذا نحن عم نحكي انه المريض he is admitted to ICU for a reason. It could be medical reason or surgical reason or for close observation or for do any procedure or whatever. طيب نحن الحين اذا بدنا نشوف نحن our role as healthcare practitioner do not keep the patient for long term in ICU. مظبوط ان نحن شغلتنا نحن to treat the patient, but at the same time في كثير من الشغل نعتبر انه المريض should not stay for an ICU for a long reason. Why? Why we need to reduce the length of stay for an ICU patient? Do you think for what reason? Why? Risk of infection. Thank you ندى. Decrease infection لأنه المريض مجرد ما يكون بالاي سي يوز reduce nosocomial infection. Thank you. فإذا أول شغلة بنقول إنه thank you we am excellent. طيب I want to ask you now. I know most of you عم بيقولوا لي just to reduce الانفكشن reduce the complication with decreasing the calls والreducing الانفكشن. طيب انا رح احكي لكم على شغلتين. اول شغله شو هي الانفكشن ممكن ياخذها المريض من الاي سي يو. فور اكزامبل او رح نتكلم عنها بعد اليوم ان شاء الله، اذا كان معنا وقت بكره رح يكون عندنا سيشن عن كل شيء انفكشن مريضه بياخذها من اكسلنت من الفالف فنتيليتد اسوشيتد نيمونيا لاماراسي ميتاسينال ريسيستنت ستاف اوريوس سودوموناس. هذه كلها it's kind of bacterial or virus that the patient he might take it from ICU. فإذا نحن كل ما خلي المريض أكثر بالآي سي يو كل ما شيء it's extra we are exposing our patient more and more to ICU. طيب شو هي الشغلة الثانية كمان؟ خلينا قصة الانفكشن فإذا اتفقنا عليها. خلينا نروح على قصة بعض الكومبليكيشن ممكن المريض تصير عنده على المريض اللي بيكون بالاي سي يو. مثلا خلينا ناخذ كومبليكيشن المريض اللي بيكونوا على الفنتيليتر بريشر ارزر بلا ما قصه الانفكشن مثل ما قلت رح يكون في عندنا سجن عندنا بكره ان شاء الله بشكل كثير كبير. طيب شو هي الريسك اللي ممكن المريض يكون عندها اذا كان على الفنتيليتر؟ مثلا دي في تي. ثانك يو سوندوس. دي في تي وات ايلس؟ نيمونيا. حكينا عن قصه الانفكشن رجعت لكم تكلمنا عنه. طيب حكيتوا سمعتوا شو عن الاي سي يو ديليريوم مثلا؟ اي سي يو ديليريوم بتصير عند المرضى اللي بيكونوا على الفنتيليتر افتر افتر اكستوبيشن افتر بوست فنتيليتر. كمان هذول بنسميه الهلوسه بيطلع المريض بيصير كمان. فاذا في كثير هذيان ثانك يو. فاذا في كثير من الكومبليكيشن اللي ممكن المريض يصير في عندنا نتيجه كل ما طولنا اللينس اوف ستي. طيب كمان حدا هون قال لي على الكوست. I want to ask you direct question. انتوا بتعرفوا كل ليله بالاي سي يو each night in ICU how much it will cost for the patient for each night in ICU. كل ليله بالاي سي يو بالعنايه المركزه قديش هل يا ترى بتكلف المريض as cost؟ 3000 والله cost more than worth. في بعض الاماكن بتوصل كلفه النايت بالاي سي يو حوالي 15,000 ريال which is too much. فاذا مثل ما بتعرفوا فاذا we have a lot of reason, we have a lot of evidence in support to the importance of reducing the cost of the length of stay. Nowadays, a lot of articles, a lot of school of medicine are talking about the about the way on reducing the length of stay in the ICU. فإذا شغلة جدا مهمة إنه نشتغل على الموضوع إنه المريض يقلل تواجد المريض. هلا ما فينا طبعا إذا كان بكريتيكال كونديشن it's not on my hand, but at least just to try to avoid any complication that it might put the patient extra. يعني مريض مثلا إذا كان عنده كلابسي or central line that's infection ما في أنا طلع برا عنده central line infected. I cannot يعني it needs to be treated. كمان الشغله اللي حكينا عنها اخير المريض صار في عنده كثير دراج انفكشن، صار في عنده انفكشن وممكن يصير في عنده دراج ريزيستنت. تكلمنا عنها بال تكلمنا عنها بالسيشن اللي قبل، هي المالتي MDRO او مالتي دراج ريزيستنت. فاذا هيدي كلها ممكن تاخر المريض انه يطلع برا الاي سي يو and it's going to cost different cost to the patient مثل ما قلنا من الماني للانفكشن والى اخره. As in this session, we are going to talk about or to discuss. أنا برجع بقول لكم نحن المعلومات نحن we are يعني بليفل نحن سلايد اللي واحد نتكلم عنه بشكل كثير كبير، مش ضروري تغيروا سلايد. I am moving, we have all the slides you see it. بس سلايد الواحد ممكن ياخذ معنا وقت أطول، مشان هيك يعني don't worry كل السلايد اللي حتشوفوها، بس نحن بناخذ شوية وقت زيادة عشان نشرح كل سلايد بالتفاصيل، لأنه بيهمنا المعلومة تكون واصلة عندكم بطريقة واضحة وكل شيء يعني يكون واضح بالنسبة لنا. طيب، فإذا in this session we are going to talk about the following objectives. What do you mean by decrease or what do you mean by length of stay? What are the purpose behind measuring length of stay? The impact of the length of stay on the organization, يعني شو الإمباكت اللي بيجي على الأورجانيزيشن. The list of factors contributing to increase، يعني شو هي الأسباب اللي ممكن تزيد or contribution on increasing the length، يعني المريض بيخلي المريض يجلس وقت أطول بالعناية المركزة. And to describe the ABCDEF bundles on the رح نشوفهم. أول شغلة رح نبلش بقصة الديفينيشن. طبعا length of stay is the accumulated number of inpatient days from admission to eventual discharge. يعني أنا ببلش أقول إنه المريض دخل عندي مثلا بتاريخ اليوم اللي نحن مثلا 28 أو 29/9، هذا أول يوم، وبصير شوف أنا هالمريض قديش لحد عندي. This is what we call the length of stay. دائما أنتم بتعرفوا upon admission يعني الطبيب بيعطي وقت مبدئي بالاخص الا بالعنايه ببعض السبيشالايز يونت مثل الاي سي يوز والى اخره. يمكن sometimes you cannot give expected time، بس ممكن يقولوا المريض مثلا بالاخص اذا مريض الديكيس ويل نون، اذا مريض الكيس الطبيب بيعرف فيها، مثلا مريض جاي بوست ترانسبلانت فور اكزامبل، طبيب بيقدر بيقول لنا انه if everything is goes normal ما في مشكله، المريض المفروض يكون على يومين على الانتوبيشن على الميكانيكال فنتيليتر، بعدين بنروح على الميني، بعدين بنروح على اللو اكتيفيتي ليفل يونت، بعدين يعني الاشياء اللي بنكون نحن بري سكادجول، يعني البري سكادجول وي كود نو ذا تايمينج، بس الاشياء اللي بتيجي ايمرجنسي وي كانت estimate the time. مثل شو؟ مثلا بيجيك المريض he is admitted through the emergency department with a post-road traffic accident and he has a severe bleeding. We send that patient طلعناه على ال OR عملنا له amputation والمريض he is on severe shock he is on ventilator. ما في بهالطريقة الطبيب he cannot estimate the length of stay in the ICU. بهالطريقة الطبيب ما في يقول له للأهل إنه أنا يعني خلال يومين أو 4 أيام أو 10 أيام المريض رح يكون برا. لا. On it's not up to the doctor, it's up to the case of the patient. So it's up on the improvement of case of the patient. يعني كيف الحالة تتطور. He might improve or it might deteriorate. إلا الطبيب ممكن يقول له نحن ممكن we could expect إنه يبين معنا شيء علامات أولية عند المريض مثلا within 10 days. بس length of stay it's not يعني بالحالات الحرجة نحن ما فينا نقدر قديش الطبيب قديش المريض حيفضل بالعناية بالقسم العناية، بينما بالبري scheduled yes we could estimate. Okay, فإذا this is the as definition. Common index used to compare performance of hospital in effort to contain cost. كمان في شغله بدك تعرفوها جدا من ناحيه مهمه قصه الاكريديتيشن. نحن شو هي المعايير اللي بتعتمد على قصه تقييم المستشفيات؟ شو هي المعطيات تعتمدوا على الاكريديتيشن عشان just to say this is a accredited hospital, this is a safe hospital, this is a no harm hospital, this is a good place, this hospital is classified as a وهذه المستشفى classified. شو هي المعايير اللي بنعتمد عشان السيفتي الاكل المورتاليتي وات ايلس؟ غير سي اس غير السيفتي وال اي اس ار اكسلنت. يعني انا ركزوا على السيشن، نحن السيشن سيفتي ريبورت وات ايفر. في شغله كمان كثير بنعتمدها part of how long patient stay, excellent length of stay. يعني مثلا في كثير من المستشفى من الاكريديتيشن، مثلا بناخذ الماجنت اكريديتيشن مثلا، نحن بنشوف انه كثير بتعتمد على الداتا من المستشفى. الداتا بتقول لك مثلا قديش عندك انفكشن، قديش في سنتينل ايفنتس، يعني ايفنتس ذات كوز هارم تو ذا بيشنت. ومن الاشياء اللي بتعمليها انه decrease length of stay. يعني اذا بناخذ مثلا قسم الطوارئ، اوكي، اذا بناخذ قسم الطوارئ بنشوف والله انه بهذا المستشفى length of stay is يعني المرضى عم ينتظروا ساعات وساعات بنفس المستشفى. ما في يعني ما بقول انه it's not a safe place، but بقول the hospital she might have another classification or she might lose points on the classification because of the decreased length of stay. لانه في عندهم كثير نسبة انتظار كثير او جدا عالية بقسم الطوارئ، مشان هيك المستشفى يعني she lose point on this. هيدي فاذا النقطة لازم كثير تعرفوها، هي قصة شو أهمية اللينس اوف ستي as definition. Very interesting session. بتشوفوا للآخر you will enjoy it too much. No standardized method of quantitating this outcome variable 7 days to يعني انا مثل ما قلت لكم انا ما اقدر احدد بشكل قديش اللينس اوف ستي، بس انا اهم شيء انه اشتغل على موضوع الكومبليكيشن بحال المريض he needs to move from ICU ما يجرى لاي كومبليكيشن يخليه يبقى وقت اطول من ICU. شو هي الامباكت to increase the length of stay؟ شو هي الامباكت اللي ممكن انا تخليني تسبب انه المريض يجلس وقت اطول في المستشفى؟ اول شغله الانكريز هوسبيتال كوست، مثل ما تكلمنا بالاخص يعني في شغله جدا بدي اقول اياها كمان تقول الاتنشن. هلا الحمد لله انه نحن عايشين ببلد كريم هنا، والبلد هون بيغطي لك نسبه الاستشفاء بنسبه 100% حتى لو قد ما كان الوقت. بس في شغله بدك تعرفوها في بعض البلدان بالاخص بالبلدان البور كونتريز مثلا بيقولوا لك I might cover you up to this point، يعني بيقول لك انا مثلا بغطيك باسم العنايه المركزه او بغطيك لحديت هيك، بس اي شيء اكسترا انفستيجيشن او شيء زياده بيقول لك والله انا I cannot يعني afford ما بغطي. مشان هيك it will increase the hospital. مشان هيك it's very important نحن more days, more extra, more cost, more procedure, more investigation, more follow up. هذه كلياتها it will have an increase. مثل ما تكلمنا يمكن من هون ما بنحس فيها كثير لانه it's well covered، بس هذا الشيء ما بيعني انه بينطبق لما كان غير مطالب بيقول لك لا we could cover you up to this point, up to this date, up to this procedure. الشغله الثانيه اللي هي over utilization of ICU resources. كيف يعني؟ شو له علاقه length of stay over utilization of ICU resources and for what resources I am talking about. أنا أي resource عم بحكي عنها. Give me example. Equipment. Thank you. What else? Beds. Thank you. Bed number. Staff. Thank you. Ventilators. Staff. طيب خلينا نشوف number of staff. خلينا نبدأ بما انه اول شيء الاي سي يو ريسورس. طبعا انتم بتعرفوا مثلا الاكويتي ليفل of ICU it's different from the acuity level from the unit. يعني انت مثلا اذا اخذنا قسم الميديكال سيرجري، قسم الميديكال مثلا in some hospital or I could see in a big number of hospital بتكون الاكويتي ليفل هي 1 over 5 or 6. بيكون كل نيرس بيكون مجبور يغطي he could cover up to 5 staff. Yes or no؟ بالاقسام العاديه. الاي سي يو patient بالاي سي يو الاكويتي ليفل هي 1 to 1 or 1 to 2. اذا كان المريض اتس اوكي اندر كنترول ستيبل بتكون 1 to 2. اذا المريض كانوا تعبانين 1 to 1. يعني اذا انا عندي 15 مريض بالاي سي يو at least I need 10 staff. اذا I am using more staff which is very هذه كمان شغله بالاخص nowadays we are working on decreasing the resource لانه staff انهك كثير بقصه الكوفيد والكورونا، وصار في اصابات كثير وصار في ريزيجنيشن كثير وصار في مشاكل كثير. مشان هيك نحن بنجرب قد ما فينا ما نعمل do not utilize our staff too much لانه يعني we might use them at anytime. فاذا نحن كل ما يكون عندي مرضى زياده بالاي سي يو كل ما يصير في عندي وقت كل ما استعمل ستاف على وقت اطول واطول. اذا بتعرفوا كمان مثلا اذا بناخذ قصه الكوفيد اليوتيلايزيشن اوف ستاف، انتم بتعرفوا مثلا بالكوفيد فرقت كثير انه احنا ستاف كان يجي على اليونت يضل من هونيك يضل طالع ما في. يعني كنا بدل ما يكون تيم A وتيم B صرنا تيم A تيم B وتيم C لنعطي وقت الستاف يرتاح اكثر نقدر نستعمله بالوقت اللي يكون في كرايسيس او سيرجيكال. فاذا هيدي الاوفر يوتيلايزيشن اوف اي سي يو ريسورسز هي وحده. قصه الباد كمان الاسره بتعرفوا نحن عندنا مثلا نحن عندنا بمستشفى هوسبيتال وي هاف 10 اي سي يو بيدز مظبوط. طيب انا وعندي اليوم مرضى على الويتنج ليست سكيدجول فور ليفر ترانسبلانت فور رينال ترانسبلانت فور وات، بس انا ما عم بقدر بلش من العمليه لانه انا my beds are occupied. انا ما في اذا مريض كان على الفنتليتر وصار في عنده كلابسي اور فات ما في انا اعمل له اكستوبيشن اقول له اطلع على من القسم برا لانه في مريض ناطر. لا نحن بهالحاله هذا المريض عم نضطر نبقي وقت زياده بالاي سي يو، وهذا الوقت الزياده عم ياخذ وقت من امام المريض الثاني اللي ناطر على الويتنج ليست ناطر يكون في بed available. And you know what I'm talking about. لأنه we have this problem everywhere. إنه we have big waiting list of patient waiting for admission. يعني هذه من الاشياء انتم بتعرفوا انه كمان يعني المريض يعني بهالطريقه يعني صار في ضرر على الشخصين. ضرير الشخص المريض الاول اللي هو اضطر يجلس وقت طويل بالاي سي يوز لانه ما قدر يطلعه لانه صار في عنده كومبليكيشن اللي هي انفكشن مثلا اخذ انفكشن من الاي سي يو اللي هو ما له ذنب فيها، وبذات الوقت عم تسبب ضرر للمريض اللي ناطر برا ليفضل السرير وما عم يفضل السرير لانه المريض ما في يطلع برا الاي سي يو. فاذا انا اي كوز هارم فور بوث بيشنت اللي هو اللي ناطر السرير واللي جالس على السرير. هذه this is what we call the over utilization of عم نستعمل الريسورس كمان اللي هم البادز واللي عم نستعمل عندي كمان شغله من الريسورس اللي بنحكي عنها كثير. برجع بقول لكم maybe والحمد لله بنقولها على طول انه it's not applicable in Saudi Arabia. لانه هون يعني صراحه الاهتمام بالناس بشكل مميز، بس رح اعطيكم شغله الاوفر يوتيلايزيشن كمان. مثلا نعتبر المستشفيات بتكون مغطيه من MOH او وزاره الصحه. هلا وزاره الصحه بتغطي الاسره مثل ما هي، بس sometimes بغير اماكن بغير بلدان وزاره الصحه بتغطي على نسبه معينه، يعني بتقول لها للمستشفى انا بغطي لك لحديت 70% من الاسره. انا بغطي لك لحديت 70% من الاسره. يعني انت بس فيك تستعملي بس 70، اذا عندك 100 سرير فيك تستعملي بس 70 سرير من المستشفى، و30 بيكونوا على الانشورنس والى اخره. بينما هون مثل الMOH بتغطيها بنسبه 100%. كمان اذا انا ما عرفت البروبر مانجمنت اوف ريسورس، بعرف اي مريض بدي ادخل والى اخره، كمان I might cause harm، وبمنع العلاج عن كثير ناس من برا ممكن يكونوا هن بحاجه انهم يستعملوا ICU. فاذا هذه كل هذه الاشياء you need to know it as healthcare practitioner. كمان من الاشياء اللي بتخلي increase the length of stay، يعني بتعلي نسبه تواجد المريض، هي مثل ما حكينا الانفكشن اللي هي الكاوتي والفاب والكلابسي اجمالا، يعني sometimes three of them. هلا نحن okay, no problem. I'm talking in English and Arabic, both language, just to make it clear. That's okay. طيب فإذا one of the others is the increased length of stay will be because of the infection. Cavity or VAP or ventilator associated pneumonia. Patient will stay more time in ICU. And here, tomorrow you will have a full session about the ventilator associated pneumonia and the collapsing and the cavity. Tomorrow you will have this session. But so far, just for you to know, any infection might lead the patient to ICU. Increase mortality. Why? Why the length of stay, it will increase the mortality of the patient. Give me example. How the increase of the length of stay in ICU, it will increase the mortality rate of the patient. Infection, DVT, infection. From infection. What we were talking the previous session, you remember? The last session in the morning time, it was what we were talking about. What? About what? Remember? لا مش stroke. Following session. Sepsis. Thank you, Iman. Sepsis. You remember the last previous session? Sepsis, it's a high risk of mortality for the patient. And sepsis, it's kind of infection. And sepsis, most of the time, it's taken in ICU. And sepsis, it will increase the mortality rate. If he has a severe infection, VAP, it might lead to respiratory failure. Central line, it's very dangerous because it's directly the line is directly to the heart, subclavian or interior jugular. And this is the increase of mortality because of the infection. Cancellation of elective surgeries. If, as we said, more time in ICUs, we are taking chance from another patient who needs to be in ICU. For example, patient post-transplant, there is no way to be in the normal unit. He needs to be in ICU. Extended waiting list, coming up. Patient is waiting today to be admitted. But unfortunately, there is no bed available because we need the beds are more occupied. We need more time for the ICU patient. For example, we have taken the improper utilization of hospital resources. How the improper utilization of hospital resources will lead to the increased length of stay. Very important information. What is the relation between the improper or utilization of hospital resource, and the length of stay. Waiting your answer. And what are the relation between the improper utilization of hospital resource and the length of stay? About what hospital resource I'm talking about? Or what are the hospital resources that I'm talking about? Like mechanical ventilator and valve. عدم استغلال الموارد بشكل صحي. Plastic tube, excellent. Improper and overutilization can lead to hospital costs. Thank you. Hi. Nurses lab diagnostic. Let's say I have a new machine in my hospital, and this machine, for example, I have the CRRT machine or the ECMO machine, and this one, it might have, for some example, if you take the during the COVID, one of the important line of the treatment for the COVID patient in ICUs was the ECMO. Yes or no? You know that ECMO, it was the main treatment for a patient with respiratory failure or on ventilator or whatever. Right. Now, let's say in your hospital, you have an ECMO machine, but we don't have a proper staff to handle the machine or to work with the machine. Okay, what will happen? You have a patient, he's on ventilator for a long time and need to be on ECMO. But unfortunately, we don't have an ECMO. And you know, a lot of patients say survive when they put them on ECMO during the COVID. بتعرف في كثير مرضى عاشوا من وراء الإكمو خلال أزمة الكوفيد. Now, if we don't have ECMO or we have ECMO, but we don't have a proper team to handle the ECMO, what will happen? More mortality, expose the patient to mortality, and the more patient will stay more time in ICU, and he might go with organ failure. This is a great and very important example about the hospital resources. We have the resource, but we don't have people to handle the resource. And I gave you example, one of the most important. I know a lot of patients during the COVID that they were in a very critical condition, ICUs, but they put them in ECMO and they survived. We know other patients in other hospitals, they went on critical condition, but they died because there was no ECMO machine, and they end with renal failure and they passed. This is a good example on the utilization of hospital resource. If you will utilize it well, you will decrease the length of stay. If we did not utilize it well, this one it might affect negatively the patient and the organization, and the patient will stay more and more time in the ICU. And for sure, extra cost. كمان burden on the families, financial and psychological. مثلا بيصير في عندهم depression, anxiety, impaired decision making. كمان the impact of the increased length of stay will not affect the patient only. As an impact ما بيكون بس على المريض. The impact will be on the family as well. They will have a depression and they will have anxiety. طبعا هذه شغله معروفه انه المرضى اللي يكونوا اهل المرضى they will suffer as well like the patient. They will have depression, they will have anxiety, and impaired decision making. Impairing of decision making. They don't know what to decide, what to do in case there is any decision that it should be taken to the patient regarding the life of the patient. And this 7 points are very important on the things that might increase the length of stay. Would you like to add something? Do you think there is any point that you could add to this slide, which is very important? Insurance, yes, already we talked about the length, the cost that some elderly with a lot of comorbidity. Just give me example if you would like to add something, how the things that it might increase the length of stay. Elderly, okay, cost for factors excellent. Elderly with a lot of comorbidity, for sure, elderly will stay in more and more time. Okay. The unavailability of step down unit, yes, excellent. Factors to economy, excellent. Thank you, Haya. As she's talking about the economical part, already mentioned it, and thank you for mentioning it many times. Now we will give you a few studies, additional impact, the type of additional impact على المرضى وعلى organization if you have increased length of stay. This is a fact sheet. It's real. هعطيكم بعض الدراسات, some of the study that was done, and just to see what was the impact on the length of stay on the patient, which is horrible. You will see. There was a study done for 323 patients with length of stay 30 days. فإذا عملت دراسة على 323 مريض, 323 patients with length of stay 30 days or more, occupy 15.7% of total ICU bed per days. Oh my goodness, you know, up to 323 patients with length of stay 30. من 323 قعدوا 30 يوم بالاي سي يوز. بهالطريقه بخلال اخذوا حوالي 15.7 of total ICU bed days. A prospective observational study, Stryker, 11% of ICU patients who stayed more than 7 days will occupy 50% of ICU resources. If you have a patient from this research, 11% of ICU patients they stayed for more than 7 days, they occupied 50% of ICU resources. اضطرينا نعطي 50% من ICU resource ل 11 مريض ضلوا بقسم العناية المركزة على أكثر من 7 أيام. Several studies, شوفوا هذه جدا مهمة. The mortality of patients with ICU admission lasting 14 days or longer. كمان معلومة جدا يعني صراحة حتى أنا فاجأتني إنه هاي المعلومة شو بتقول؟ بتقول إنه 50% من مرضى الاي سي يوز اللي ضلوا بالاي سي يوز على أكثر من 14 يوم they passed away. 50% of the patients that they stayed in ICU for more than 14 days, they passed away, which is terrible. They say it's a miracle. No, it's not. Look, it's up. Let me tell you, Haya, very important point, very important point. To survive from ICU or whatever, there is different condition. First of all, this is the will of God, you know this. Second, the case of the patient. If you have a patient with a very complicated case, it will be very hard to manage the case in any place. If you go to the first hospital around the world and you send a patient with multi-organ failure with a lot of illness, it will be impossible to survive that patient. Second. Third is the availability of a specialized hospital, a good hospital staff and resource. And already, I gave you example of the ECMO. If you have a patient, ICUs, and they have a COVID patient, and they need to go to ECMO, but there is no ECMO, what will happen? There is different point that it might, and I know a lot of patients, they were in a very critical condition, they put them on ECMO and they survive with no complication at all. This is based on one research. It doesn't mean everywhere. Okay? This is one of the research that was done. It doesn't mean that it's applicable everywhere. This is how it doesn't mean that كل مريض يكون ICU it's going to die or it's going to be complication. Majority they are going to survive. Now we have a lot of evidence. We have a lot of things that it's supporting our patient. مش الموضوع بس أنا just for you to know a lot of factors. A lot of factors are playing a role on the increased length of stay. كمان 70% of the patient just they recover after 2 weeks. يعني just اعطيناكم الاشياء المعلومه فزعتكم شوي بس هنا كمان 70% من المرضى they said more than 10 weeks they recover. كمان بس شو هي الفاكتورز اللي حكينا عنها total increase length of stay disease acuity مثل ما حكينا some of the cases it's not on our hand. نحن في بعض الحالات we cannot manage it. يعني مريض with multiple organ failure I cannot, it's not on my hand just to say patient will say more time. Because COPD patient complication مثلا delirium بعض المرضى بيحتاجوا re-intubation. Intubation بتخص المرضى يعني for long time. If there is a accidental extubation, especially المرضى بيكونوا كثير agitated, we need to intubate again or more sometimes because we cannot keep the intubation for a long time. نحن بنروح على ال TT tracheostomy. We cannot complicate or we cannot put the patient under mechanical ventilator for a long time على ال ETT and the tracheal tube. We need to go for that tracheostomy tube. Well, family decision. What do you mean by family decision? It will increase length of stay. How the family made the decision and what are the relation with the family on the decrease of length of stay? How the family made the decision will increase the length of stay. Complete treatment at home, no transfer to rehabilitation. Excellent, thank you. Now this is the time to go to the rehabilitation center, but I have insurance for that, but I don't have insurance for rehabilitation. كمان الفاميلي ديسيجن از يو نو، يعني معظم العائلات هنا كمان بتفضل تعطي المهم العنايه الماكسيموم للعائله تبعها، مشان هيك بيفضلوا يخلوهم they might say that I'm ready to pay the extra amount of money for me, there is no problem, but keep my patient more. And this is applicable more in the insurance hospitals. بالاخص المرضى بيكونوا المستشفيات بتكون private hospitals or insurance hospitals. They will look for money mainly. They might keep the patient more time. They might say, okay, no problem. If this is your will, we could put the patient more time in your unit. But now, this is one of the solutions. It's just to create an organizational strategic priorities in the decreased length of stay. This is very important. It might be very useful to you, to your organization, how the hospital should plan to increase or to decrease the length of stay. First of all, the first one is to revise the discharge process. How do you think we could revise the discharge process, and how the discharge process will decrease the length of stay? Give me an example. How a good discharge process will decrease the length of stay. أنا عم بعطيكم حلول مشان نخفف نسبة الاختصاص بالاي سي يوز. تواجد المريض. One of the things, first of all, thank you, Iman. The first question, does the patient needs ICU, yes or no? The other things, like what? For example, the first question that needs to be asked, did the patient really needs ICU, yes or no? And this is based on the assessment and reassessment of the patient. For example, the same, if the patient he has a central line, always put it in your mind that the doctors always in ICU they prefer to put a central line because this is very easy for management in case the patient become, you know, in a critical condition. But if you will put the central line more time, this is more exposure to infection, and the patient will stay more time. In case there is no central line, no need for central line, the central line needs to be removed. No need at all. This is if you keep the central line more time, more exposure to ICU, and more increased length of stay. Discharge process, you need to have a clear pathway for the discharge of patient. For example, patient, this is a line of treatment. It could be done or could be given in the unit. No need for central line. No need to keep the patient more time on ventilator. We could start the weaning process. Now, for example, patient post-transplant, after 2 days, he might go for extubation. Then he might stay 1 day in ICU, and the 4th day, خلاص, he will go to the unit. هذه بنسميها discharge process. If you don't have a clear discharge process, we will increase the length of stay, not only in ICUs, even in EMS. بس احنا الحين عم نتكلم على موضوع ICUs لأنه it's specialized for ICUs. بس احنا إذا بنحكي على موضوع الطوارئ, it's more and more information. How much it's important to decrease the length of stay. Expand the hospital model on the home health care services. كمان كيف الهوم هيلث كير سيرفيسز it will decrease يعني شو علاقة الهوم هيلث كير سيرفيسز بالديكريز لينث اوف ستي؟ وات اذر اللي شو له علاقة البيت بالمستشفى؟ كيف أنا إذا عندي a proper home health care services كمان it will affect the length of stay in the hospital. Give me example. Tracheostomy, thank you. كيف التراكيوستومي يا أخي؟ Patient could stay at home with the tracheostomy instead to be in ICU. I am sure in your hospital or any place, there is patient who are on tracheostomy for long time. Yes or no? Am I right or no? بتشوف إنه في كثير ممرضات such cases we are giving a reality. Such cases, they will no need to be in ICU because they are using more beds. فإذا if you have a good healthcare services, a good healthcare service, it might decrease the length of stay because the case that could be treated at home, no need to stay in ICU. First, second, إذا أخذنا قصة stroke مثلا بيقول لك أنا I need to keep my patient because the patient needs rehabilitation. He is hemiplegic post-stroke. What is the alternatives? Just to send the patient home and take the patient from time to time to a stroke center who could take care. No need to stay in ICU for rehabilitation on, or no need to stay in the hospital no need to stay in the hospital just for rehabilitation. The rehabilitation, it could be done at home or it could be done in a rehabilitation center. أنا شفت شو أهمية الهوم هيلث كير على موضوع decrease length of stay. إذا أهم شيء مثل ما اتكلمنا هي discharge process لازم يكون في عندنا proper discharge process. We need to have a discharge project. كل مستشفى المفروض يكون في عندنا discharge project. كمان مش بس admission criteria يعني ممكن الطبيب أي مريض يفوته على الاي سي يوز which is wrong. اوكي كمان بده يكون في عندنا admission criteria. For example, the admission criteria would be just patient the certain patient is post MI or patient post let's say RTA or whatever. ما في مريض مثلا he might be in low acuity unit ممكن يكون على مثلا بدل ما يكون بالاي سي يو. No need to be in ICU. Some of the patients they could be in low acuity unit for observation. Later on, if it become desaturated or there is the unresponsive or whatever, ممكن يخطوا على ICU. بس ما ضروري we should not put the patient in ICUs for no reason. What are the bundles? Are the American Nursing Association? What are the bundles? What are the bundles for preventing or to length of stay? First of all, assess, prevent, and manage pain. Why do we need to assess, prevent, and manage pain? How to assess a pain first? How we could assess the patient. This is what we call the ABCDEF bundles as per the American Association of Critical Care to decrease the length of stay. First of all, we need to work on decreasing the bundles or the pain. How we could tell me how to assess, prevent, and manage the pain. Give me example, please. Pain score. How would you put the pain score in? Up to 10, yes? One, you could say that the patient has a pain. Faces, if he is conscious, yes? If the patient is unconscious, how would you do? Frac and flag, yes? Okay. As an أول شيء, we need to assess if the patient has a pain. Even if the patient is on ventilator, there is a way to assess the pain if he is conscious or unconscious. As I don't neglect this point, even the patient, if he is on ventilator, if he is intubated, he could be having a pain. preventing of pain by giving the medication on time, and management, just up to that case. The spontaneous awakening trials and spontaneous bleeding. What do you mean by awakening trials? How we could say that the patient, he could be on, let's say, out of ventilator or weaning process by doing what kind of trials or assessment? For those who are working in ICU, no sedation, vacation, or GCS, ما فينا نعمل لمريض on ventilator. فينا نعمل what إذا كان sedated نعمل الراس or Richmond agitating scale. الراس، أوكي؟ لأنه نحن الراس just to see if the patient he could go for extubation. لأنه هو بيكون sedated، فأنا نعمل decreasing للsedation شوي شوي مشان نشوف how the patient he will respond. ما فينا نضرب على extubation directly. لا، he need to go through a weaning process, and part of this is the RAS or Richmond agitation scale. بنشوف المريض, we will decrease sedation, and you will see how the patient will reacting to the sedation. كل ما يعمل more reaction, كل ما نقلل ventilator settings, ساعتها المريض will go for extubation. نبلش على weaning process and we'll go for extubation. Choice of analgesia and sedation. We cannot keep the patient sedated for a long time لأنه might have a lot of complication. وحكينا قصة بالأخص المرضى اللي بيكونوا on sedation or sedated. What would be the complication? المرضى اللي بينعطوهم كثير sedation. What would be the complication? تكلمنا عنها هذيك الساعة. لكن عنها. Okay. What else? But في شغلة اللي بيكونوا long sedated, fentanyl وإلى آخره. But what will be the complication? Will be the zoran fentanyl. What will be the complication? It will be the ICU delirium. تكلمنا عنها. المرضى اللي بيكونوا معطين كثير sedation بعدين بيصير في عندهم ICU delirium. تكلمنا عنه. Okay. طيب. فإذا delirium assessment and prevention كمان تكلمنا عنها. And early mobility and exercising. How we could early mobilize our patient in ICU. How we early mobilize our patient to ICUs. And how much it's important for the patient. PCA or patient every 2 hours, okay. What you do every 2 hours? Physiotherapist doing wrong. Positioning of the patient excellent higher. فإذا this is كمان في كثير من الدراسات إنه نحن وقت بنعمل early mobilization of your patient, it will decrease the length of stay. كل ما نعمل early mobilization by our patient, we will decrease the length of stay. This is very important. Family engagement and empowerment. What are the relation with the family on the decrease in length of stay? What are the relation? When the family engagement and empowerment, it will decrease the length of stay. Thank you. Khadija بتقلنا or the patient could decrease the thrombus. Excellent. No risk of DVT, deep vein thrombosis. But another movement, we will decrease the DVT, the sulfur DVT, بيصير في عندك pulmonary embolism, and the patient will stay more and more time in ICU. How the family engagement and empowerment will decrease the length of stay. Prepare the family to support the patient. What do we mean by family engagement? We have how the engagement of the family will decrease the length of stay. Update them about the case. Give them a clear expectation. The family, they tell them that you should be aware that the patient, he will be on tracheostomy. Tracheostomy, it requires a care. There is no need to be in the hospital. He could be at home. We need to give them a clear expectation. Okay, by engagement and empowering the family, by giving them a good expectation, and sometimes teach them, empower or teach them, for example, how to do a tracheostomy care, or how to do a proper care, or at least how to give, let's say, how to turn the position every 2 hours or whatever. And prepare them as the patient, he might not return to this very طبعا. They need to be aware that it might be impossible just to return back like before, but however, they could work on the improving of life. Like example, ليش المريض بده يكون to stay the whole life with pressure injury? It could be avoided. Why to stay with suffering with pain, with other complications? It could be avoided. As the engagement of the family, it's a very important step on the continuity of care with our patient. بس نحن بالجايد لاينز اللي هو البي اي دي جايد لاينز هو pain agitation and delirium. It was أول شيء 2002. It was just focusing on the sedation and analgesia. Now we add the pain, which is very important. The pain and more evidence shows that the pain will decrease or increase the length of stay. We need to be careful on assessing and giving the proper treatment for our patient in case he has a pain. As an assess, we talk about the A, B, C, D, E, F bundles. If you would like to take a shot about this, it's very important, and this is how we could decrease the length of stay in our. تكلمنا عن البين سكيل, and as you see, this is how we could assess the pain. طبعا كل مستشفى كل مؤسسة بيكون عندها a proper pain scale. It's not, it's not something that across, but we have the same concept that we need to assess the pain for our patient. تكلمتم عن الراس. How much? وعن الديليريوم how much it will, we need to avoid the last point, just we need to avoid the delirium لأنه الديليريوم مريض extra sedation, more delirium, because if in case he might have mortality. شو علاقة الديليريوم بالمورتاليتي؟ لأنه patient if he has delirium and he is confused, he might fall down. يعني إذا مضيع المريض he might fall down and he might have a delirium. Length of stay, more time of ventilator, post re-intubation and long-term wellness. Any question? Do you have any question regarding this session? Did you enjoy it? Any new information? Anything just you need to add? فزي ما تكلمنا, it's a very important session, and you need to know about the length of stay because it might affect not only the patient, the family, and the organization as well. Everybody could be affected by the length of stay, and our role just to work on decreasing the length of stay. الله يعطيكم العافية جميعا. شكرا. يعني انا شكرا حضرتك انه انا ما بشتغل بالطوارئ ولا بس it was interested انا I'm very happy with this انه نسمع من ناس ما بيشتغلوا بالطوارئ او بالعنايه المركزه but they enjoy السيشن واعطيتهم معلومات اضافيه. هذا شيء يعني احنا مبسوطين فيه صراحه. طبعا نحن العنايه الغسيل الكلى رجاء هي كمان part of critical unit نعتبرها لانه المرضى بيكونوا يعني كمان part of critical unit. طيب, if there is no question, now we will give you 5 minutes break, and after 5 minutes, we will be with Dr. Hussein.
Guys, are you with us? Is the sound clear and loud? Excellent, excellent. So, guys, today this is the last, session. Hopefully by 3:15, 3:10, we'll be able to finish, and you're good to go home after that. So it's been a long day. We discussed many things. We discussed about the ICU, length of stay. We discussed about the medication. And now one of the important skills that you will see in ICU and emergency is the tracheostomy in terms of care, bundles, and the daily maintenance. So hopefully by the end of the session, we'll be able to review the anatomy of physiology and the upper and lower respiratory system, okay? And list the indication for insertion tracheostomy tube in patients whether in emergency or in ICUs, and the list of complication for tracheostomy tube, discuss the type of tracheostomy, and discuss the standard of care that comes for taking care of a patient who is in tracheostomy. I will not be going in detail about the anatomy and physiology because our main is, our core objectives is to focus in the tracheostomy. So if we look into the anatomy of respiratory system, and you can see the oral cavity with the nasal cavity and going down to the epiglottis, and this is what it goes. This is the upper respiratory tract for the patient, okay? The pharynx and the nasal cavity and the oral cavity, including the epiglottis. You see the epiglottis and yes, Akram, any questions? Okay, can I proceed? Yes, Zainab, I can see your text, I can see your messages. If you do have a question, please post them in the chat. As you see, the epiglottis is responsible for covering the larynx during the swallowing, and this is what prevents aspiration while the patient is eating. Your larynx box is function mainly for the production of the sound. You move down to the trachea, which is a cylinder shape, cartilage shape, okay, and this is the airway tube, where it can be divided in a right, bronchi and left bronchi, and you see the bronchial airways. And then you go to the lungs, right lung and left lung, and you go to the functional cells in the lungs, which is the alveoli at the end of the bronchi and the bronchioles. And this is mainly where does the gas exchange happening in the alveoli. Not sure about the number, but as far as I remember, maybe we have millions of alveoli. Okay, Zahra, she's saying the voice is not clear. We're trying our best, okay, and we to make the voice and the sound clear. So as we said, the alveoli is the the functional cell in the lungs, which is responsible for the gas exchange. You have muscles that help for the breathing and for the ventilation. You have intercostal muscles. You have also a phlegmatic muscle here that helps also with the contraction and relaxation. And this is help to work with the volume, with the pressure that inside the lung and intrapleural pressure. So all of this regulates the breathing process for the patient and allow the air to enter and gas change to happen. And when it comes to the tracheostomy, it is a surgical creation of an external opening in the second, okay, and third, fourth ring of the trachea. It can be a temporary option. It can be a permanent or placed during an emergency if the patient, needs urgent tracheostomy. And you can see the thyroid cartilage here. You can see the cricothyroid membrane and cocoid cartilage. Just below that, there is insertion of the tracheostomy. The tracheostomy site or tube is often called a trach and can be done at bedside or an emergency, or sometimes we do it in ICU as well for patients who are long ventilated patients and they need to put them, remove the tube and insert a tracheostomy for them. What are the indications for tracheostomy? Why we need to insert a tracheostomy for the patient? Usually trauma. In emergency, we're talking about trauma. We're talking about congenital, airway obstruction, infection, foreign body aspiration, malignancy. We're talking about congenital airway obstruction. We're talking about the diseases that could lead to laryngeal edema or that can block or close the upper airway, and those patients they ended up having tracheostomy. Airway clearance, that's another reason why we need a tracheostomy. Secretion that cannot be cleared due to weakness and condition require long-term, ventilation, airway support, Guillain-Barré syndrome, spinal cord injury, myasthenia gravis, severe brain injury. Those, patients, they don't have the ability to clear the airway. So it's better to have them, because of the weakness that they have, like with a neurological insults that happen to the brain, or the mechanism or the pathophysiology of the disease itself can lead to the weakness of the upper airway, and they need, support to clear the secretions. Long-term intubation is, as Nadal discussed with you guys, the length of stay. Now, a patient, stayed for a quite long time in ICU, the patient will end up for complication. And usually they try to wean those patients, from the ventilators. Now, some of them, they manage to wean them and they can be, normal breathing and nasal cannula, then they can remove the oxygen totally. Some of them, they fail to wean them. Now, those patients who are failing to be weaned, they switch them, to the tracheostomy, because the long-term intubation can cause, as all of you, can cause infection, can cause pneumonia, and to avoid all of this, they switch them to a tracheostomy. Now, sometimes it could be elective or prophylactic. When patient had head and neck surgery or radiation therapy, they know ahead of time that this patient is a good candidate to have a tracheostomy before they start treatment of radiation or starting doing the surgery for the patient. Now, physiological changes occur what happened to the patient. We need to understand what will happen to the patient after insertion or after placing a tracheostomy. Voice loss, and impaired swallowing. That will have one of the things that could happen to the patient. Loss of filtering as well, altered sensation and cough reflexes. Will be loss of warming, humidification action of the nose. These are, the things that happens when the patient placed in tracheostomy or they inserted tracheostomy for them. That's why, those patients who need oxygen or in oxygen, you need to humidify, warm the oxygen for them. Make sure that they get assist by a speech therapist, swallowing test done for them, and it's a multi-services working in those patients between, ENT, speech therapist, nutrition, dietitian, just to make sure that all these areas are covered and the patient can maintain his airway, no aspiration can happen, and the patient can eat and can have, a good, nutrition status while he's having the tracheostomy. The actual procedure and Hanu, she said, how long does the loss of voice last? Let me just finish and we'll explain what happened exactly with the patient. The actual procedure, it's a surgical tracheostomy. Surgical tracheostomy refer to open method performing procedure in operating room by ENT surgeon. Some ENT surgeons, they prefer to take the patient in a controlled situation in the OR and do, the procedure there. Now, some of them, they can do it bedside, depends on the situation of the patient. Usually performed for patients with upper airway tumor, fairly precaution tracheostomy, anatomical abnormality, short neck, and obesity. and it can be done in emergency, as we said. Post-surgical tracheostomy, the patient may come back with a stay suture around the tube. If this is post-surgery, the suture facilitate the tube placement and make sure the tube is, secured. And it should be removed, for crucial between 5 to 7 days while the stoma is forming. So they try to make sure that the stoma is kept open for at least 5 to 7 days. That's why they suture it. So if the tube does not go out and the stoma might close. So in this case, suturing will help, to keep the tube in and will make sure the stoma will never close. The first tube change may be happen after 5 to 7 days of the insertion or ordered by the operating physician, whether ENT or, as a hospital guidelines, we do it between 5 to 7 days. Do you hear me very well, guys? Yes, excellent. Precaution, percutaneous dilatation in tracheostomy. That's one of the kits. That's one of the kits that you should have. We talked about, about the intubation, the airway card. So if you have an airway card in emergency or ICU, you should have percutaneous dilatation in tracheostomy. Is done using percutaneous dilatation technique. So have 1 or 2 of these kits in case if you need urgent, tracheostomy bedside in emergency or an ICU. ICU sitting in ICU, they do it. Yes, Tahiyya, it is at ICU. The first tube change should not be formed before 14 days of the initial insertion because stoma is very tight and the risk of tracheostomy collapsing is high. That's the first tube change. During the first 2 days after procedure, patient is uncomfortable. They are not used to have this, the tube. They need to adjust their trauma surgery, pain, fresh incision, presence of foreign object in the trachea, and inability to communicate through the speech. So this is most complicated or things that we need to be worried about. Make sure that the pain is free after the, they insert this one. Make sure that, they has inability to communicate through the speech. The patient may feel choking sensation and can take 1 to 3 days to adapt to the breathing through the tracheostomy tubing. Also, one more thing is about, clogging or, these, especially with pediatric patients, they might get easily because the diameter of the tube is small. So there might be with any secretion, any blood that can close the tracheostomy. So you need to watch that very closely with the pediatric patients. Let's go and see the procedure. We should see if this can work or not. Can you see the video? Can you see the video, guys? Okay, let me share the video with you. the video now? Yes, excellent. I'm not sure about the voice, if you can hear it or not. Let's go back from the beginning. Because I'm not sure what's the problem with that. With the voice. The purpose of the video to show you how they do the tracheostomy, percutaneous dilatation tracheostomy kit. So this is the procedure, guys. You've seen it, how they inserted using the percutaneous dilatation tracheostomy kit. And this is what we are referring to have one in your crash cart, so it's ready if we want to use it for patient care. So let's continue. Do you hear me now, guys? Do you hear the voice, the sound? Excellent, yes. So what are the risks involved in tracheostomy? The major risk that you will see is the bleeding. Whoever is doing the surgery, he has to be privileged. He has been should be trained to do that, especially when it comes to high-risk patients. ICU patient, or morbidly obese patient, short neck patients, okay, or patients who's having tumor. Those they need special, specialists to do the procedure. Patient also might develop respiratory cardiac arrest, having some respiratory problem, desatting, hypoxemia, reaction to medication and anesthesia. It's not related to the procedure itself, but it could be to the medication that can be given preceding the procedure or in conjunction with the procedure. Anesthetics, medication or agents that can be given to sedate the patient also might carry a huge high risk on the patients. Complication post tracheostomy are classified as early and late, Sharif, I'm not sure why you cannot see the chat, but it's very clear here. What are the early complications, the post complication for the tracheostomy? The early life-threatening complications are accidental tube displacement. This is what we talked about, that the tube might merge, might go outside, okay, might, with any source of cuff, the tube could, dislodge. Blocked tracheostomy tube, commonly with blood clots, as you see, the mucus plug, especially with the pediatric, that's lack of humidification and suction. Especially, I want you to take care also of pediatric, excellent rather bleeding, one of the major complication. When it comes to pediatric, because the diameter of the tube is very small and they might, easily get mucus plug that can close the tube and patient will be hypoxic, will be irritable, will be agitated. So they need a close observation. Sometimes it could happen damage during the surgery to the surrounding structure, leading to visible hemorrhage, bleeding, surgical emphysema as well from the insertion or techniques, trauma caused by over vigorous suctioning technique, and pneumothorax could be one of the early complications that could happen, to the patient, and these are life-threatening situations. The late complication is infection, skin breakdown, and you see most of them. They have, a lot of discharges, skin start to be fragile, and sometimes they have, injuries around the stoma site. They're complaining about this. Tracheal stenosis due to overinflation of cuff or rigorous, suction. That's why we need to be soft and not, aggressive when we do suctioning for them, because this may proceed to tracheal stenosis. Tracheoesophageal fistula, and this could be also from the technique from the insertion where they can, mistakenly cannulate the esophagus. Either tracheostomy tube should be meet the following criteria. It should be rigid enough to maintain the airway, flexible to limit the tissue damage, and should induce patient comfort as well. As a procedure, or as a definitive airway for breathing, it is quite difficult for the patient who passes through the time when they need tracheostomy, especially if they're going to permanently having tracheostomy in their life. So it is a shocking news for them, seeing them breathing through the tube, not the normal way. So you have to at least reduce this damage or this complication by a good education to the family, to the patient, and make sure that you do a good cleaning care of the tube, and make sure patient comfort with the new devices they have. The most common brand of tracheostomy used is we're using Sherry in our Nasal here. When it comes to the tube itself, we have the outer, cannula, we have the inner cannula, and we have the cuff here. Now, the main body of the tube, which is passing through the trachea, is the outer cannula. Inner cannula is removable. As you see, this is, comes inside, this one, and it is removable. Two lock connectors prevent, prevent the build-up secretion at the end of the tip of the outer tube. Comes as a non-fenestrated, reusable, and fenestrated. Different sizes, different, types, whether some of them fenestrated, some of them non-fenestrated, reusable. These are the inner cannula. They can be removed, they can be cleaned, okay, and they can be easily twisted, lock connector. Now the outer cannula cannot be connected to ventilator, okay. The only inner cannula, it has the ability to be hooked and connected to ventilator. The cuff is, as you see, all balloon in the distal end of the tube, which inflated can provide seal between the tube and the tracheal wall. The cuff can be deflated on the insertion or inflated to protect from aspiration and allow positive pressure ventilation. So the main reason is to prevent the aspiration and prevent air leak around the tube. It's important to remember that inflated cuff carries a negative effect on cough and swallowing, as well risk of inducing tracheal wall damage, because it might, with the friction on the mucosa of the trachea, can damage the mucosa. It's very important to check cuff, pressure constantly and keep the level between 15 to 25 millimeter mercury using cuff pressure manometer. Usually the RT who does that, who have a manometer, who can measure, the cuff inflation balloon. I forget what's her name. Don't you ask about, tracheostomy and loss of voice. Now, if your patient is having a cuff, usually they don't have permanently, but when the balloon is there, there's no air entry that where voice can, happen. If your patient have a laryngectomy, the whole, box, laryngeal box is removed, so there's no voice. Other than that, if your patient have, a regular tracheostomy, the voice will come back after, a couple of days, and the patient can go home speaking. The cuff pressure, as we said, this is the manometer. RT is always. Yes, Abdullah, thank you. The cuff tracheal tube inflatable at the surround shaft tracheal tube near the distal end. When inflated, the cuff press against the tracheal wall to prevent air leakage and pressure loss from the lung. As we said, we don't want there any air leak happening or pressure can be lost, especially if your patient is hooked with ventilator. Indication for the cuff the tube immediately post-operatively to prevent aspiration of blood serious flow from the wound. Seal the trachea to prevent air leak, especially mechanical ventilation, prevent patients. Prevent aspiration of leakage from the tracheoesophageal fistula and prevent aspiration when it comes to the laryngeal incompetence. As we said, 15 to 25 millimeter mercury. We talk about the hyperinflation of the cuff. That the hyperinflation of the cuff, what will cause inflammation, okay, bleeding, tracheal erosion, necrosis, as who mentioned this one, can cause ischemia. Abdullah, thank you very much, Abdullah. So the necrosis is the same like ischemia because of inflation of the the cuff. Tracheal stenosis, tracheoesophageal fistula, okay, because the wall of the trachea became very fragile and might be easy, having any opening. Arterial fistula, cuff to herniate and goes because it goes down, tracheomalacia, dilatation of the trachea. If, on the other hand, if we look into the problem from the other part, if we underinflate the cuff, the seal around the cuff will be inadequate, increasing risk of aspiration and causes loss of positive pressure ventilator with the patients. So you have alarms in the ventilators. The pressure that being set up in the ventilator will not assure adequate, pressure inside the lung or adequate ventilation. What are the nursing considerations for tracheostomy patients with cardiac tubes? Unless the patient on mechanical ventilation, cardiac tube should be only inflated following a physician order. That's the most important. In cuff tubes model, the cuff and inflation system should be tested for leakage before. And this is, I guess you've seen it in the procedure. They tested, even in the tube, in the tracheal tube. The most important thing before they insert, they check that there's no, leakage in the cuff itself, and the cuff is working before they insert it. Cuff pressure should be monitored using appropriate pressure manometer. We saw the manometer, minimal occlusive volume technique or minimal leak technique. Who does that? Respiratory therapists usually who taking care of the manometer to make sure that the cuff levels pressure is normal. Nursing staff will measure the cuff every 12 hours, but usually they don't, adjust the pressure. The one who adjusts the pressure is the RT, but they will observe to make sure that the patient is not, the cuff is not being deflated or inflated. Especially for ventilated patient who is having, who require, a very sensitive or high, settings on the ventilator. So you want to make sure that you deliver the appropriate, volume for the patients and the pressure are maintained throughout the ventilation cycles. Parts of the tracheostomy tubes, okay, we have the pilot balloon, it's an external, okay, this one, balloon connected to the inflation line to the internal cuff. When internal cuff is inflated, the pilot balloon is also inflated and vice versa. We have the flank, the neck plate, and this is support the main structure of the tube and to prevent tube from descending into the trachea, allows, allows plate, to be skewed with ties and suture. The tube cord size types are indicated in the neck plate. Introducer, we've seen that obturator or introducer. It is placed inside the outer cannula and the tube during the insertion. So this is a obturator. This used only at the insertion to reduce the trauma of the tube insertion. Obturator should be removed once the tube is inserted to allow air entry assessment of correct placement. So these are the parts that comes, with the tracheostomy and how they fix it and make sure that it is in the right place. Other part, the occlusion cap. I'm not sure. Have you seen this, guys? Have you seen the occlusion cap? Can you answer, please? Have you seen them? No. She said no. Yes, no. Natalie saying yes. So the occlusion cap is a solid piece of plastic, can be, yes, rather excellent, used before weaning. A solid piece of plastic can be placed at the end of the 15mm hub, blocks all airflow through the tracheostomy. It can be used in the end stage of weaning patient from tracheostomy. Can be easily removed if the patient needs suctioning or in respiratory distress. Now the fenestration. The fenestration is a single or multiple holes. You've seen this, I guess you've seen it many times. You've seen this, in the superior curvature of the shaft of the outer cannula and inner cannula. As long as there's an air, those patients, they can speak, and the airflow, they will be able to speak. The 15mm adapter, it's a 15mm sized hub to allow attachment to ventilator, circuit, and ample bag. So this is what we talk about. This one, these ones, you can attach patient to ample bag, you can attach patient to ventilator. Without these, kind of hubs, you cannot attach patient to ventilators. Fenestrated versus non-fenestrated. As we said, fenestrated to facilitate improved speech. Fenestration allow increased volume of air to be forced through the larynx during exhalation, to improve swallowing, function, restoring normal airflow, some of the protective mechanisms of normal swallowing, and ease decannulation. Do not attempt ventilate patient, that's emotional. If your patient having a fenestrated one, if you try to, if your patient all of a sudden became hypoxic and you would like to bag your patient or using the bag mask device, or with the presence of these holes, that means a lot of air will be escaping and air leakage will be. So do not attempt ventilate, provide air, oxygen using a bag or suction patient while the green fenestrated inner cannula in place. When it comes to suctioning for the patient, if the patient has one of the following, excessive secretion, decreased oxygen saturation. If the patient became tachypneic or bradypneic or tachycardic, we go with the further suction. Agitation, irritability, increased intercostal muscles, sweating. These are all signs, there's sometimes block or mucus block or clot or, excretion, thick secretions, noisy breath sounds, decreased breath sounds, or ineffective cough. Sometimes they try to cough, but, they don't have that good accessory muscles where they can, able to expectorant the cough. Change in skin color from the baseline, they became a little bit dusky, they became, is not as pink as it should be. Reduce expired airflow from the tube during expiration. Collection of sputum in the specimen, sometimes this is required, suctioning for the patients. Always auscultate the lungs, maintain aseptic technique, wash hand, and aseptic non-touch technique, make closed system, determine the suction catheter size, and there's like, determine the suction length, how far you can go with this, your suction catheter, until you feel resistance or your patient start, coughing, then approximately you withdraw the catheter 0.5 to 1 centimeters. Hyperventilate, oxygenate your patient, okay? Suction pressure should be between 100 to 120. We said we need to avoid this over suctioning for those patients. It could lead to many tracheal stenosis, we mentioned all the complications of the over, the suction or aggressive suction. This is how you choose the catheter size, the right size, okay? So step one is to take the internal diameter of the tube, then divide it by 2 and multiply it by 3.3. For example, if the size is 6 of the internal diameter, okay, is 6.4 millimeter divided by 2, we're going to have 3.2 millimeter. 3.2 millimeter, we multiply it by 3.3, so you'll have 10. We don't have 10.5 catheter, so you go to catheter of 10 size. This is at least, will give like 50% of the diameter of the tracheostomy or hub is mere open. So you will not close it and causing the patient, hypoxia. So only you cover 50% of the diameter of the hub if you're using this formula. Tracheostomy care should be done every shift for the patient and PRN. Equipment, all the needed supplies are inside. I'm not sure if you do have guys, tracheal kit in your at your hospitals. Do you have ones? These are, comes, ready-made, and it has all the equipment that needed to take care or clean or change, the inner cannula, clean the inner cannula, change the the dressing. Do you have those ones? Yes or no, guys? Yes, excellent. So you have these ones, okay? Hydrogen peroxide, this is, you have to bring it from the department, and it's a sterile procedure that you need to maintain the aseptic non-touch technique. Make sure, patients who are in a chronic, tracheostomy, they are very familiar. They do it at home for themselves, okay? Family, they do it for them. So, those patients, they know when they need to do tracheal care, when they need to do a suction. They're living with this tracheostomy and know how to troubleshoot, when to suction, when to clean, and when to change the tube or the inner cannula. But for us as healthcare provider, We need to explain the procedure for the patient, position patient in a semi-fowler position or upright, it depends how, how sick your patient, okay? But at least you need to be in a semi-fowler position. As we said, we hyperoxygenate and suction trachea and pharynx as needed. Open the trachea, pour the sterile saline and put the hydrogen peroxide, okay? Remove the old cannula, wash your hands, put the new gloves, sterile gloves, and clean your inner cannula with the hydrogen peroxide and sodium chloride, dry it very well, and put it back for the patient. If your patient having a ventilator, you need to have another, disposable or usable cannula where we can insert it and hook the patient. As we said, the hub can be connected to the ventilator. The outer area of the tracheostomy is cannot be connected to ventilator. So that's why you need to have a spare disposable inner cannula where you can, just right away put it and hook your patient in ventilator. Now, if your patient, that's if your patient ventilator. If your patient on oxygen, that's fine. No need for a replaceable or usable inner cannula. It can be done with while the open outer cannula is open. You check the site of the stoma, clean the site of the stoma, and make sure that is using the gauze that comes inside, with the tracheal set. Change it, the tracheostomy ties, okay, always you have 2 nurses, and make sure it's not, very tight to the neck, because if you tight it very well, this may cause, pressure injuries to the patient and develop pressure ulcer. So make sure the trach will not come out of the patient. So you remove one side, you keep the other side, you tie one side, then you remove the next side and you tie the new ties. Emergency equipment, when you're taking care of patients who have tracheostomy, you need to have 2 types of tracheostomy, smaller size and same size. Suction need to be ready, suction tubes are ready. You have ambu bag, appropriate obturator should be present, Yanker, tracheostomy tray, and the most important thing is at least, we don't, request, to have a tracheal dilator in each patient, but at least, should be ready in the crush cart in case of, the tube is out and you need to dilate the stoma, you should have a tracheal dilator available. Always we remind, about the pain level for the patient, the comfort level for the patient, education. Those, patients who are chronically, they develop sometimes, a respiratory infection, which is, MDRO, multi-drug resistance. So when you do respiratory pressure for them, when you do cleaning for them, when they have, trach care, please maximize your barriers. Most of those patients are MDRO, so you need to be with them in a single room. Refer to speech therapy for speaking valve application as alternative method for communication if your patient is chronically in tracheostomy and no cuff, it's non-cuffed tube. In all ventilated patients, report to respiratory therapist, physician if there is oral noise, drop in tidal volume, ventilator pressure, sudden increase in secretion, any signs of respiratory deterioration. This is what tells you. Check also the cuff, the manometer for the patient to make sure that the requested, amount of volume and the pressure that are set up by the ventilator are delivered to the patient. This mainly about, tips, procedures, nursing consideration, and care for patients who are with tracheostomy. That's all for today, guys. Thank you very much. If you have any questions, please write them up. If no question, we close the session, and thank you very much.